highlighting some important topics, and then talk on community outreach program. And amongst us, we are fortunate to have the founder, chairman, Bihar chapter, Dr. Ajay sir. Let us give him a big hand. I remember the day. Now, here is the person whom we are waiting for. Let us give him a standing ovation. Professor Anuj Maheshwari.
Swagatam aapka, swagatam, swagatam, swagatam aapka. किस तरह से नमन मैं करूं आपका, किस तरह से नमन मैं करूं आपका. स्वागतम 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 आपका, स्वागतम 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 आपका.
This song reminds me of a very important fact, that in the peaceful times when we are thinking of arranging conferences, webinars, seminars, we are thinking of fulfilling the vision of our leader. It is because of the fact that somebody is sacrificing their life at the border. And in the Operation Sindoor and follow-up, many of our brave Jawans, they have lost their life. So, to start the program, before starting the program, I will request all of you to stand up 1 minute in silence for the souls who have left us in the honor of our country. Let us sit down, please. Before starting anything, I will narrate one incident about Dr. Anuj Maheshwari. A couple of years ago, while at a dinner or something, we were talking to each other. And I asked him whether he can come down to Darbhanga if invited. He told me Darbhanga is a big place, important place, cultural place. I can go down to even the remotest of the place, even if that means traveling in a train by 12 hours. Today, when I went to hotel to meet him after he came to this thing, I was thinking he has left today from Kochi. He woke up at 5 o'clock or so, got the morning flight there, via Hyderabad he has come. So I was expecting a tired Anuj Maheshwari, but he was looking more fresh than myself. I asked him the secret. What is the secret? And his answer was one word. His answer was passion. That is Professor Anuj Maheshwari for you. He had many visions, out of which some which I know I will narrate to you. His first vision is to create a research force from India, and he wants to involve all doctors, particularly young ones, postgraduate students. And this diabetes update is dedicated from his side to the postgraduate student. At the same time, he realizes that all these talks in the conferences are of no value unless it goes to the remotest corner of our country. That is why Rural Outreach Program, which we will be having tomorrow morning, and he will be narrating his vision for that. I will not go into details because I can talk hours and hours about him. And when such a great leader comes to the power, he's the president-elect of RSSDI, and he'll be representing India at different forums. We are lucky to have him. He will inspire the whole country, no doubt. Now I will invite Supriyo Mukherjee, the Bihar chapter chairman, to the dais for his kind words.
We are in short of time, so I will not talk much about it, but I just welcome you. It's a good evening and a very warm welcome to each one of you. At the very outset, I extend our deepest gratitude to Dr. Anuj Maheshwari, our esteemed National President, RSSDI, Professor of Internal Medicine at Hind Institute of Medical Sciences, and a widely respected academician and researcher. As a former governor of ACP India chapter and past president of Asia Pacific Society of Hypertension, his visionary leadership continues to shape and advance diabetes care both in India and globally. That I expect so, and I wish so, and I expect so. We are equally honored to have with us one and only the legend, Dr. Ajay Kumar, our founder chair, our patron, and world-renowned teacher and researcher whose life works continues to inspire us all. A special welcome to our revered and distinguished Dr. U.C. Jhasa, that I am not saying him, head of the Department of Medicine, whose academic excellence, clinical leadership, and even readiness to support the cause of RSSDI are truly commendable. Our heartfelt appreciation to our guest of honor, Principal Ma'am and Superintendent Ma'am of DMCH for their valuable support and their gracious presence. I take this opportunity to welcome a man of both vision and action, Dr. B.K. Singh, our past president, whose leadership made the RSSDI Bihar chapter stand tall with pride and purpose. I also extend a warm welcome to Dr. Ajoy Tiwari, my friend, and our special invitee, Dr. S.C. Jha, the dynamic intellectual, our organizing chair, the wise man, Dr. Shaival Guha, chairman-elect and founder-treasurer, Dr. Subhash Kumar, vice chairman and one of the most successful secretaries of RSSDI Bihar chapter, Dr. Anand Shankar, our extraordinary founder secretary, Dr. Vijay Kumar, mature and very brilliant chapter secretary, Dr. Naveen Kumar, our exceptionally diligent and precise in execution convener and organizing secretary, and I extend our warm welcome to our trusted treasurer, Dr. Manish Kumar, whose dedicated stewardship continues to guide us, and to all the esteemed dignitaries, professors, students, distinguished guests present here. Today's CME and outreach at DARBHANGA reflect our commitment to equitable diabetes care, bringing clinical excellence to the grassroots. I welcome all faculty, providers, and volunteers who join us in this meaningful journey. Thank you once again for being here. Let the session begin with a purpose and participation. Thank you very much.
For next session, we have got chairpersons. The first session, in fact, about diabetic food and Ajay Tiwari. For Ajay Tiwari, I will not give the introductions, chairpersons will give. But one thing I know, that he is an excellent physician and diabetologist, and he is an equally efficient and good photographer also. I'm sure that it is the loss of photography world that we are having him with us. To come to the dais, chairpersons invited Dr. P.K. Thakur, Dr. S.N. Goet, Dr. Bharat Kumar, and Dr. Sweta Burma, please. And kindly introduce our speaker, Dr. Ajoy Tiwari.
It's my privilege to introduce the speaker, Dr. Ajay Tiwari. The name that's a spell, and the topic is recent update in diabetic footer. Come on, Dash, and please give me a. Okay, thank you.
Thank you, all my friends from Bihar, especially Dr. Respected B.K. Singh sir, Supriyo sir, S.C. Jha sir, Sabal Goa sir, Anand Bhai, Subhash, and all dear friends from Bihar. It's always a pleasure to be here among friends. So basically, I'll be taking you through some very interesting things which is happening in the field of diabetic foot. So a lot of things are happening, and but first I will try to give you the basics of diabetic foot, because I think if you're talking about the frontiers, we should know what is the basics, what is the nitty-gritty of managing a diabetic foot, because it is the most neglected part of our practice. And I must tell you, in last 25 years, I have tried to go to various places to just learn about diabetic foot, and with gradual practice, I could do a bit in this field. So this is basically, I'll start with, we have a very long tradition of foot care, and the first podiatrist was none other than Lord Krishna. He gave respect to his poor friend Sudama, and that is the first incidence of the diabetic foot care in our history. And I think it's a very humbling experience. If you touch the feet of someone, you feel that you are grounded. So that is one thing, and I must tell you that after this particular talk, everyone should start examining the feet. That is very, very important. So there are a few facts. Every 20 seconds, someone is amputated, and this has come from Armstrong et al., who is considered the father of diabetic foot. The lifetime risk of people with diabetes to develop a foot ulcer is 34%. So a big, big problem. More than 50% of diabetic foot ulcers become infected. So that is compounding the problem. Karela neem chada. And 20% of the diabetic foot infections result in amputation. So basically, what is diabetic foot? So basically, it's a very broad term. So it's a collection of foot problems which are not unique to, but occur most commonly in diabetic patients. So basically, what is happening? There is a formation of a callus or a pressure of, or an area of high pressure, and basically there is a hemorrhage down below, and subsequently that is leading to an ulcer. So this is the most usual presentation of that, but lot of things are coming into picture. So it could be diabetic neuropathy, it could be a microvascular disease, macrovascular disease, limited joint mobility, and to compound that, smoking and other things also can give rise to, can add to this problem. So all these problems, autonomic damage, sensory damage, motor damage, so all and compounded by infection leads to diabetic foot. So we are talking about diabetic foot, but I said that we will be first discussing the basics. So the basics are, basically we have to see the pulses, the dorsalis, medius and posterior tibial. we have to look for the foot sensation, that is the loss of protective sensation, and temperature assessment. So our hand is the best technology. So that is what I want to tell you in the first part of the talk, and in the second part of talk, because I have been asked to talk about recent updates, so I'll tell you about this. So first and foremost thing is, I always tell that the physician, the treating physician is the first person who is writing the FIR, that is the first information report, because the coming events cast their shadows beforehand. So we have to understand that if we are proactive and we are looking into this, we can prevent these complications. So this is the 3-minute diabetic foot examination. So it comprises all the 3 portions of this. So the first part is that you have to ask a few questions. These are the leading questions: previous leg ulcer, foot ulcer, or lower limb amputation surgery, any prior angioplasty. So you get a history of this, and then you ask the patients about specific symptoms like burning or tingling in legs or feet, leg or foot pain, changes in the skin color or skin lesions. So this is something you ask in the first minute, and then what to look for. So we have to look for, does the patient have discolored, ingrown or elongated nails? Are there any signs of fungal infections? Does the patient have discolored and or hypertrophic skin lesions, calluses or corns? Does the patient have open wounds or fissures? Does the patient have interdigital maceration? So all things have to be seen. And at the same time, which is the most important, that you have to see for the loss of protective sensation, and also you have to palpate the pulses. And most important thing is that you have to examine the footwear of the patient also, because that is also very important. And then this is a very good opportunity to teach the patient. So what all things he should do to see these things. And the most important things that we have with us is this 10-gram monofilament, because this is telling you us about the loss of protective sensation, because what we want to see, the foot at risk. So this is the usual foot examination that we do at our places, and these 4 points which are marked with dark blue, they are the most important points, and they are never to be missed. So you have to see the monofilament test, and that is the right way of doing it. You have to make a C, and this is how you do it. Then never miss a diabetic foot. So even this very small blister that you are seeing over here, so this could be down below, this could be like this. So never miss a diabetic foot. If person is saying something, and they will always say that, sir, chota sa blister tha, there is nothing like that. But please look into it, because the looks could be very deceptive. And a basic about what do we have to do. So this is an analogy with the Hindu religion, that is the Brahma, Vishnu, Mahesh. So the triumvirate of diabetic foot management are debridement, offloading, and sugar control. So these are the basics of this. So the debridement of necrotic tissue, infection management with antibiotics, offloading techniques, moist wound care dressings. Now we say that the moist environment is better to promote wound healing and the management of the underlying ischemia. So this is one feet which has got almost all the points which show towards a neuropathic ulcer. So you see all dry skin, and these are the neuropathic ulcers. Then there are cracks in the soles also, and then when you debride this, you see something like this. And this is what this reddish part, which we call as the granulation tissue, is what we want to see. So this is another case. These all are from my own center. So this is all keratinized hind foot ulcer, and then if you debride it, it becomes like this. And over a period of time with an offloading device, this is basically a gloves which have been reversed and covered with a tape. So this is how we offload them, because if you don't offload them, they will never heal. That's the point about this. Then a very important thing is that once you start getting something to do with the diabetic foot, so you also have to understand what are your limitations. So in ischemic foot, you have to refer to a vascular surgeon, osteomyelitis, obviously to an orthopedic surgeon, septicemia, venous ulcers and Charcot's foot, they need specialized care. So you have to think about it. So this is a venous ulcer, this is an ischemia, gangrene, then this is an ingrowing nail, and these are the multiple mice bites. This is an absolutely insensitive foot, and the mice is biting every time. So we say that the pain is the greatest gift of the God, because if you have pain, you will understand. If you don't have pain, you won't understand. Then coming to diabetic foot ulcer, so this gives a lot of digital health is coming in. AI is coming, so many things are coming. So lots and lots of things are happening in the field of diabetic foot ulcer. This is the vibra tip, which is now replacing the tuning fork. So basically this has got an inbuilt motor and this is a disposable device. So you can take the vibration sense with this. You just push the button and you do this thing. Then this is a very interesting device and it is available in India. This is a NeuroTouch device. So it has got all the components of diabetic foot assessment. It has got vibration sense, perception, cold, hot, and then this can be downloaded to a cloud and you can get the complete report. So all the modalities of sensation can be tested with a single device. So this is something new and it is available in India and we are using at our center. Then pseudoscan is another device which is used for autonomic neuropathy, assessment of pseudomotor function, and it basically tells about the peripheral neuropathy. Then another device which is very interesting, this is the ischemia assessment. So usually we are doing Dopplers, we are just listening the sound, but here you can see the waveforms also. As you are listening the sound, at the same time you can see the waveforms. It is monophasic, biphasic or triphasic, so that can be seen. Then mobile health applications are there. So patient self-monitoring apps for daily food checks, easy, for example, Foot Snap, My Foot Care. So wound imaging apps with size and depth tracking, so this can be done, and educational and reminder-based mobile platforms improve compliance. So lots and lots of people are doing, and even some of the people from India are also doing this. So basically you can see, and this is being sent by a mobile device, a mobile camera to the cloud, and this is being assessed by a diabetic foot ulcer specialist. This was what we did, and now I think it looks very primitive. This was we did in 2014. This is a published paper. So this we did with the Podia Harris mat. So but now we have got very interesting things like smart wearable integrated with mobile platforms. We have got devices which can sense the pressure sensing smart insoles and socks like Orifix, Sironia, smart socks. So they are available. So you can see instead of going for a device, the socks that you are wearing, they can also tell about the plantar pressure and the temperature. The temperature variation is the most important thing. That tells you, that prognosticates that this particular part of the feet is, can have an ulcer in the future. So that is one thing. So these are the devices, FitC, Orifix, Podiametrics and Siren. So basically a wearable sock, and this is where you stand every day and you get this device. So these are the things which can be which can be done, and this is the Orifix SI custom sensor insole. So this insole is reading both the pressure as well as the temperature variations. Then Siren socks, again this is the variation that this is being, the device, the implantable device is put inside the socks itself. And this is the Podiametric smart mat. So every day in the morning the patient stands on this, so it gives the reading of the pressure and the temperature. So this is the most, this is one which has been used most, and this is the most, there are a lot of studies with this particular Podiamet device. Then we can have digit soles. So these soles are basically reading the entire, so they are sensing the different parts of the feet, the pressure sense and the temperature sense, and this is being communicated through this particular sensor to a cloud, and this is being read by the sensor. Then we can have smart soles. Then this is a very interesting development. This has come from our own Indian Institute of Science, Bangalore, and they have made this. This is basically this is a digitally printed foot sole, and there you can, this has got sensors, and this can adjust the foot pressure as per the load which is coming to the feet. So this is a unique self-regulation footwear. It is 3D printed, customizable to foot sizes and walk styles, snapping mechanism, arches in the saddles, and snap to inverted shape when pressure beyond a certain threshold is applied. So basically they are assessing the pressure and then they are manipulating the amount of offloading which is needed. So this is how it is done. So this was what we used to read as regard to the sensors, and this particular thing is changing as per the how the pressure is changing, so the dynamics of this sole is also changing. Then this is another very interesting innovation, and this is there are these micro shock, mini shock absorbers. So basically when the pressure is applied, so this is basically a iron colloid, and it changes its viscosity as the pressure is increasing or there is an ulcer. So basically the foot, they are offloading the foot then and there. Then we can have bioengineered skin substitutes like collagen-based or cell-based constructs, promote faster granulation and healing. Approved examples are Dermagraft and Aptigraft. We can have skin substitutes, growth factor therapies, we have been using them, but now we have got more innovations because if you are applying these growth factors directly to the skin, there was a lot of, it was not being absorbed properly. So now they are having collagen meshes, and in that they have incorporated these growth factors. So that is one way of this. Then we can have stem cell therapies, use of mesenchymal stem cells, potential to regenerate vascular and soft tissue. So these can be autologous or they can be had from other sources also. So this is how you do it. So these scaffolds are used, and these are the mesenchymal stem cells which are applied over the, these are the scaffolds. These are the collagen scaffolds. So they are applied over there. So then we can have smart bandages also. So basically they are also, these are the, they are the sensors over there, and this is a disposable bandage. So this is attached to this, and as per the temperature which is coming, it is basically, they are basically releasing the antibiotics. Then a localized oxygen therapy, that is the Netrox. We have heard about hyperbaric oxygen therapy, but this is a localized oxygen therapy. So this is also coming up, and these devices are available, and they have already been used in clinical studies and have shown beneficial effects as regards to the wound healing and wound closure. Then 3D printing in DFU management. So this is also very interesting that we have got customized orthotics and wound covers. So 3D printing can do this. Then we also have the 3D bioprinting of skin and its appendages. So this is also now being applied. This is also being tried in the academic institutions the world over. Then we have AI-based risk prediction and decision support. So you have got large number of database, and from that you can have a risk prediction tools as regards to what is, which is the point which is have a high prediction of ulcers. So technologies to improve adherence, just 2 minutes more, to improve adherence to the protected footwear. So this is basically a technology to see what is having this. So this is a PAM tag, and it is one of these technologies introduced to improve adherence to offloading. You give a shoe to a patient, but he is not wearing to it. So basically these tags can tell the treating physician that the patient is wearing those shoes or not. So this is something which is very interesting. Then we have robotic platforms for 3D wound imaging in clinical settings, AI-enabled virtual clinics and chatbots for patient triage and guidance. So all these things are new. So, but at the end of the day, I'll say that it is the most important technologies that what you are doing to your patients. Are you watchful? Are you looking to them? Are you palpating them properly? So I would say that for one mistake made for not knowing, 10 mistakes are made for not looking. So that is very important, that you have to see, you have to examine your patient properly, touch their feet and see what is happening over there. So no patient deserves this. A few minutes can save this catastrophe. So this is a completely destroyed foot with maggots over there. So no one should have this type of outcome. So this is what we did. Ek din ek pradesh 1000 पैरों की जांच. So last time in this diabetic foot initiative of our own RSSDI, we did 10,000 tests in one day. So this is what we did. So thank you for patient hearing, and I am open to questions.
Thank you, sir, for the lucid and illustrative talk. We all know that the UP RSSDI chapter is growing wonderful under your secretaryship, and the house is open. The house is open for only 3 questions as we are running short of time. Only 3 questions are invited from the audience. No questions? Okay, we can then end up the session. Thank you, sir, again.
Since there are no questions, I will request the speakers to kindly honor our speaker. Sure. Chairpersons to honor our speaker. Now I will request Ajay. I will request the speaker to honor our chairpersons. दीक्षा कहाँ है? तुम जाके कर दो। कहाँ गई तो? ठीक है। इसके बाद हमको क्या करना?
For the next session, I request Dr. V.N. Jha sir, Dr. Ajay Kumar Mishra sir, Dr. K.D. Yadav sir, and Dr. Milind Jha sir to please come up on the stage as chairpersons of the next session. I request our chairpersons to please introduce the speaker to the audience.
Pleased to welcome our teacher and excellent teacher and a very good orator, and my teacher when I was in doing my MD, he was my RMO, Sir Dr. S.C. Jha. His topic is initiating the insulin therapy in type 2 diabetes mellitus.
This is slightly revised topic considering the vision of Dr. Anuj Maheshwari, insulin in type 2 diabetes and community barriers. Friends, respected seniors, honorable chief guest, our Professor Anuj Maheshwari, and founder chairman Dr. Ajay Kumar sir, and dear students. There is a tsunami of type 2 diabetes mellitus sweeping across the globe. And mostly this is occurring in the middle and low income countries like India. Nearly 1 million Indians die, and major cause per year, and major cause of blindness, stroke, heart attack, and kidney failure and lower limb amputation. And this is despite the fact that we have got a lot more molecules than we had in our student days. This is the simple slide, yet my most favorite slide, taken from UKPDS, which shows that at the time of diagnosis of type 2 diabetes mellitus, 50% of the beta cells are already gone. And some of the complications have already occurred. And what is more appalling is that this decline in beta cell function starts possibly 10 to 12 years earlier. And this goes on after the diagnosis also. Only thing which we can do, we can slow it down. Now, we'll be discussing about the insulin therapy. Managing diabetes is a balancing act. Why? Because we aim for we aim for lower glycosylated hemoglobin. But when you are aiming for lower A1C, then chances of hypoglycemia is there. That should not occur. Because for want of 20 grams of odd glucose, you may lose the life of the patient. So this is the glucose triad which we are aspiring for: fasting, PP, and A1C. And we all know that postprandial glucose is a very important fact. And about 2 or 3 decades ago, we are not aware of that postprandial is also this much of importance. And this is the unfortunate part. This slide shows the higher postprandial glucose excursions in Indian population. Why it is that? In the Western food, the quantity of carbohydrate is around 40% or so. And in India, poor country, lot of rice, patla dal, a lot of aloo-like vegetables, no salad, so the percentage is around 75 to 80%. Now, type 2 diabetes is, the treatment efficacy chart is there. Every other molecule has got limitation to the glucose lowering effect, except insulin, which has got the unmatched efficacy in reducing glycosylated hemoglobin. So there are plenty of benefits. We all know cardio, neuro, protective, glucose lowering, vasodilatation, beta cell rest, anti-thrombotic, antioxidant, anti-inflammatory. So there is no doubt that insulin has got a lot of benefits. So there is a rationale for insulin earlier. When it is done, it has got its own importance. Even the studies have shown that early intensive insulin treatment causes remission also in some studies. There are the studies of Ryan et al., Wang et al., and Chen et al. So early insulation is very important. This is another important slide which I will like all of my PG students to remember, that aggressive glycemic control at the very outset is very important, and it causes, in advanced stages of the type 2 diabetes mellitus, there are so many comorbidity and other factors. In early stages of type 2 diabetes mellitus, you can do. And it will lessen the death from the diabetics, reduce the rate of myocardial infarction, microvascular complications later on, and peripheral vascular disorder. And what is the appalling fact? That because of the clinical inertia, the patient stays on oral drugs for so long. And insulin initiation is very late. At insulin initiation in SOLVE studies, average glycosylated hemoglobin was 8.9. So these are the barriers which we aspire to remove. There are barriers on the part of the physician also, because many of our colleagues are not so much aware of what can be the complication, how insulin should be administered, what precautions should be taken. And our is an insulin-phobic country. Your patient will say that, doctor, give me anything but don't give me insulin. Many patients believe that insulin is the ultimate medicine to be given. And it is only the end stage people, they start crying and weeping. So the proper explanation, proper education, that is the key. And financial issues, they should also be addressed. Now, I am not going to talk in detail about indications of insulin, we all know that. Now, this is how this blood glucose is there. It remains at the basal level, and with food it increases. And similarly, the insulin level also increases. These are the basal level insulins available in the market. This insulin, NPH, insulin, Detamir, insulin, Glargine 100, Glargine 300, and insulin degludec. And short-acting insulins are there, the soluble insulin, then this glulicin, Lispro, Aspart. Fast-acting Aspart is also there. My aim is to give an idea, overview of how we can start the insulin. Basal insulin is the best way to start. If you want to break the community barrier, it is best to ask the patient to take once a day insulin, and that too before yourself. That will remove the fear, anxiety about insulin. What I do in my clinical practice, I always give the first dose in front of myself. And I myself try to convince that there is no problem, and insulin needle is so small that nothing will happen. So basal insulin regimen with oral hypoglycemic drug that will control fasting glucose level tremendously. Sometimes there is issue about the postprandial level, which is usually taken care of by the oral hypoglycemic agent, but in all cases there may not be control. Then we think of other causes also. So basal insulin regimen is a simple regimen and easy for early initiation. But this regimen doesn't offer optimum control of the postprandial hyperglycemia. This is just to show that there are certain bodies which advocate that this combination, first injectable should be GLP receptor 1 antagonist, agonist like liraglutide. And in these cases, combination with insulin works wonder. And they have got a better efficacy and also the safety profile. This is the basal bolus treatment program with rapid acting and lower acting analog. Basal insulin once, and before each meal, you can take the prandial insulin. Basal bolus regimen remains the gold standard because of the, but it has got the disadvantages. Multiple pricks are there and more complicated to support and teach. problems of hypoglycemia, weight gain is there, and needs full patient motivation. So premix insulin, the advantages are the more accurate dosing is possible, lesser injections, but disadvantages are the fine tuning is not possible. Because if you are giving premix insulin morning, evening, then the patient's lifestyle should be so regular to match the insulin regimen. So recommendations of ADA 2018, twice daily premix insulins are recommended for intensification following failure of basal insulin, and sometimes 3 times premix insulin can be recommended. Now this is the Indian guidelines, one-time premix insulin initiation, which can be switched over to twice daily and thrice daily, similar to ADA. Now this slide is very important. Start with basal only, then go for basal plus. Basal plus is basal insulin and plus giving one prandial insulin with the biggest meal of the day, and basal bolus is giving basal insulin once and prandial insulin before each meal. Starting dose, we will like to know that type 1 diabetes, it is 0.1 to 1 unit per kg per day. Type 2, it is 0.2 to 0.3 units per kg per day. I'm not going into the details, but the overview is important. And though we have got a lot of molecules, still there is a big role for insulin, and it should be kept in mind, and the treatment should be individualized. Premix insulin, you cannot prescribe to a patient who has got the erratic lifestyle. So discussion, education on various options are there. Insulin offers maximum efficacy in the terms of glycemic control, and as you have seen that in the SOLVE study, at the time of insulin insulation, the glycosylated hemoglobin was 8.9. That has to be avoided. The early initiation should be there, and it can reduce, the early initiation can help reduce long-term complications. Basal insulin is preferred as augmentation therapy for OHA because this is just one day and it will remove the community barrier. Replacement therapy includes basal bolus and premixed insulin, glucose control, cost, side effect, quality of life, all those should be considered. One size doesn't fit all, one prescription doesn't fit, it is not fit for all the patients. Though basal bolus resembles physiological insulin secretion, premix analogs are good options. And premix insulins and novel insulin co-formulation come with distinct basal and prandial glucose lowering effect. Premix regimen has less complicated and less demanding glucose monitoring. Initiating with premix insulin offers improved efficacy and safety and offers the advantage of simplicity. Thank you all for the patient hearing.
Very informative lecture, sir. Thank you very much. House is open for question.
Excellent, as usual, Dr. STUDYOF. My question regarding the insulin therapy, what is over-basalization and how can you recognize in your clinical practice?
Actually, the total dose of the insulin should be calculated, and 40 to 50% should be taken as the basal part. The over-basalization means that the fasting will be over-controlled, but the prandial insulin will be increased. Yes.
Wonderful presentation. I must say, I must congratulate you, but would like to say to the postgraduates and all others, RSSDI has also issued its guidelines, and not only they are the clinical practice guidelines, we have made them segregated guidelines like in-hospital management guidelines, guidelines for the diabetic foot patient, guideline for the hypertension in diabetes, guidelines for the heart failure. So we have also given these kind of guidelines, and I'll request you, one session you can keep on one day full dedicated to the guidelines.
Okay, sir.
So API guidelines, what you have shown, they are now little more, they are not that much updated at the RSSDI guidelines, because every second year we are updating them.
Yes.
And again this year we are coming up with the new version of the RSSDI guidelines. And these are available on the website of the rssdi.in. So all the postgraduates can go to the rssdi.in and they can download all guidelines and they can use whatever, wherever they want to use.
Thank you, sir.
Thank you, sir. Now session is over.
I request our chairpersons to please felicitate the speaker. I also request our speaker to please felicitate the chairpersons of the session.
Now I request Dr. A.K. Gupta sir, Dr. Praveen Kumar and Dr. Manish Kumar Prasad to come to the dais as chairpersons, and they will be inviting the legendary figure, founder, chairman, Bihar chapter RSSDI,
Good evening, everybody. It's my pleasure to present before you Dr. Ajay Kumar, who does not need any introduction. He is well known to everybody across Bihar and across the country. He is going to tell a very important topic and most challenging situation in the management of diabetes mellitus, cardio-renal protection. And most of you know that a newer molecule has raised a new hope. I think he will elaborate it and we can enrich our knowledge. Now I can request Dr. Ajay Kumar to kindly proceed.
Honorable Chairpersons, Honorable Principal and Superintendent, DARBHANGA Medical College, our Chief Guest, National President-elect Dr. Anuj Maheshwari, dear colleagues, postgraduate students, ladies and gentlemen. It was almost impossible for me to come this evening here because of certain commitments at Patna, but then the charm of Dr. Sudhir Kumar Jha will completely disarm you. And that's what exactly happened, and I had to come here. But I am very happy to see this audience, and I hope that I do justice with the topic which has been allotted to me. I think it's very important for all the clinicians to appreciate that the fundamental reason we treat type 2 diabetes is to prevent cardiovascular and renal outcome, besides, of course, prolonging life and preventing complications. And to do that, it's absolutely important that we understand what exactly is happening in type 2 diabetes, which is driving the cardiovascular and renal outcomes. And three factors are extremely important to understand. The first is the metabolic factor, which includes basically a good glycemic control. And the second important factor is the hemodynamic factor. And in the hemodynamic factor, as you can see on the top left, it's not only the systemic blood pressure, but the intraglomerular pressure in the kidney is also extremely important. But these two things, which has been talked about a lot in the past, the metabolic and the hemodynamic factors, hitherto had completely overlooked the role of the third factor, which is inflammation and fibrosis. And when you combine these three important issues, then you realize that whether you talk about the kidneys or you talk about the heart, the basic histological structure of kidney, like the glomerulus and the tubules, they undergo a lot of hypertrophy, mesangial expansion, fibrosis, and the same thing will happen in the cardiomyocytes, the vascular endothelium, and at the end of the day, both kidneys and heart will stop functioning in their proper way. So what do? You must have some strategy to answer these metabolic, hemodynamic, and these fibrotic and inflammatory factors. For hemodynamic factors, we have the anti-diabetic drugs, for the antihypertensive drugs, and in that antihypertensive drug, the best is the RAS inhibition, whether it is the ACE inhibitor or the ARBs, but any antihypertensive drug will give you a smart reduction in the systemic blood pressure. But to reduce the intraglomerular hypertension, it is imperative that you use a molecule like SGLT2 inhibitor, which is not basically an antihypertensive drug, but it still reduces the intraglomerular pressure along with the RAS blockade. For the metabolic factor, you have all the anti-diabetic drugs, but as I said, that if you make a Bollywood movie, I was talking during the daytime in another lecture at Patna, if you make a movie in which the two superstars of the film industry, Amitabh Bachchan and Shah Rukh Khan, they are in one film. What was that film? 2000, first in the millennium, Muhabbatein. And that was a runaway success. It had to be. With Amitabh Bachchan and Shah Rukh Khan in one film, you cannot imagine what that great thing will do. So when we talk of the metabolic control of diabetes, nothing can beat the combination of a GLP-1 receptor agonist and the SGLT2 inhibitor. But if you really want to prevent the inflammation and fibrosis, you have to think of the mineralocorticoid receptors. And mineralocorticoid receptors overactivation is primarily responsible for all these cascade of fibrotic changes that I was talking about. And when you look at the mineralocorticoid receptor over there, we have the steroidal and the non-steroidal part. The steroidal part, of course, cortisol, etc. And we already have drugs like the aldosterone antagonist, spironolactone. We also had eplerenone, which we have been using in cardiac failure. But to do actual reduction in the inflammation and fibrosis, we have now a molecule which is called non-steroidal mineralocorticoid receptor antagonist, which is finerenone. So how finerenone is different from a spironolactone and eplerenone is very, very important to understand. The most important thing is that finerenone has got very nice receptor activity, as you can see here, 3+. But what is more important is its selectivity for the receptors. And if there is greater selectivity, the gynecomastia and the other side effects like that, they will not be there with this particular molecule. And the next important thing is look at the half-life of this drug, which is only 2 to 3 hours. So what will happen? The side effects like hyperkalemia, even if they occur, you simply withdraw the drug and the hyperkalemia will quickly disappear. So that makes it a very safe drug, and its distribution between the kidney and the heart and the other tissues is also 1:1, unlike 6:1 for a spironolactone and 3:1 for the eplerenone. So all these mechanistic importance of finerenone give it a very high pedestal in preventing the onset and development of fibrosis in chronic kidney disease in type 2 diabetes. If we talk about chronic kidney disease, it's very important to understand that we should be looking both at the eGFR and also the urinary albumin creatinine ratio. Why? eGFR is a function, is a measure of kidney function, whereas albuminuria is a reflection of kidney damage. So unless you assess function and damage both, you will not be doing justice to your patient. And when you look at the patients of chronic kidney disease, in fact, not many of them will actually reach the stage for dialysis. Before that, they will die. And therefore, it is very important that whatever action you take much early in the natural history of the disease, not later. And therefore, it is imperative that all patients of type 2 diabetes should be annually screened both for the eGFR and the urinary albumin creatinine ratio, because the increasing level of albuminuria correlates with the exponential rise in the adverse renal and the cardiovascular outcome, as you can see on this particular slide. Now, when we look at the patient, and this is the heat map, K-DIGO heat map of chronic kidney disease, and if you only look at the eGFR of this particular patient, What do you see? This patient is in the green zone. But the moment you add the urinary albumin creatinine ratio, this patient goes into a moderately severe category. And therefore, when we are looking at a patient of type 2 diabetes with chronic kidney disease, you have a combination of eGFR and urinary albumin creatinine ratio, and then you will realize that I'm dealing with a very serious problem. And then you have to identify the particular drug which will address this particular abnormality. And SGLT2 inhibitors, without any doubt, stands out at the top of the molecule, because if you look at the mechanism of action of SGLT2 inhibitor, through its natriuretic effect, it reduces the intraglomerular pressure, and it gives all the benefit to the kidney. And through its the main mechanism of reducing the blood sugar, again it gives you the cardiovascular benefit. And then through the antioxidative, anti-inflammatory, the third On the other hand, if you block the SGLT2 receptor by using an SGLT2 receptor blockers, like any of us dapagliflozin or canagliflozin or whatever, then what happens? That the sodium reabsorption is lessened because you are driving the sugar through the kidney. So now increase sodium delivery to the macula densa, so we restore the tubuloglomerular feedback. And that leads to, again, restoration of the adenosine secretion. And when you restore the adenosine secretion, there is vasoconstriction. And when there is vasoconstriction, the intraglomerular pressure is decreased and the glomerular filtration improves. So that is the wonderful mechanism of action of SGLT2 inhibitor, which makes it the supreme drug to reduce the cardiovascular and the renal outcome. And when you look at all these mechanisms of action of SGLT2 inhibitors, then it doesn't surprise you that when this molecule was subjected to the first famous cardiovascular outcome trial called the IMPAREG trial, we had such astounding results of cardiovascular protection with this particular drug. And it was not only, I'll do that, don't worry, I'll get it there. So I told you about all these slides. And then I told you about this heat map and the patient. This is the mechanism of action. This is the normal, when you have normal sodium and glucose coming. Okay, okay. ठीक ही चल रहा था यार मैं थोड़ा पानी दे यार मेरा आवाज फंस रही है हो गया ठीक ठीक So I talked about all these things. अरे फिर गायब हो गया I have it here. Okay. So this was the, once you restore the tubuloglomerular feedback, you get all these benefits. So I have already alluded to all this, but the very interesting photograph that I want to show you, that when you use an SGLT2 inhibitor, look at the real-time picture. This is the afferent arteriolar vasodilatation, and after giving SGLT2 inhibitor, you see the vasoconstriction, and that is how it reduces the intraglomerular pressure. And then it doesn't surprise you that in the IMPAREG outcome or the any of the cardiovascular outcome, CANVAS trial, DAPA-C, all of these trials, you had the benefits with SGLT2 inhibitors. When you look at the dapagliflozin trial, it is different from the IMPAREG and the CREDENCE trial or the CANVAS trial. Why? Because here 60% of the patients did not have established cardiovascular disease. They had only increased risk factor for cardiovascular disease. What does it tell you as a clinician? That you not only get the benefit of SGLT2 inhibitors when the disease is advanced. Now you have the data which tells you that even in the earliest stage of the disease, when you use an SGLT2 inhibitor, you derive a lot of cardiorenal benefit by using a molecule like SGLT2 inhibitor. That is what you see in the dapagliflozin trial. And then we have the data in diabetic patients with or without heart failure, or heart failure patients with or without diabetes. And in each one of them, whether you look at the cardiovascular outcome or the renal outcome, all of them, practically all of them, are statistically significantly better. And that makes SGLT2 inhibitors absolutely fantastic molecule. In the cardiovascular outcome trials, when they looked at the renal outcomes, once again you see each one of them is beneficial. That again put the seals of approval that it is not only cardiovascular outcome, but the renal outcomes were also benefited by the use of this molecule. The comparison of the CREDENCE trial with the other DAPA-CKD and EMPA kidney trial is in the fact that once again CREDENCE trial involved patients who had very serious kidney disease. So that again tells you that when you combine and pool the data from these studies, that again tells you that irrespective of the stage of the disease, whether you're talking about the mild disease or fairly advanced disease, the benefit of using SGLT2 inhibitor is always there. This is the renal composite with dapagliflozin. Once again, I reiterate this fact that this trial had patients who were 60% only had high risk factors but not established heart disease. This is again the CREDENCE trial. I will not go into the details. Now, DAPA-CKD was a revolutionary trial. Why? Because this trial for the first time showed the benefit of SGLT2 inhibitor irrespective of the fact that whether the patient has diabetes or not. So even in non-diabetic CKD, the benefit of SGLT2 inhibitor was demonstrated in the DAPA-CKD, which was further shown in the trials of empagliflozin also. Not surprisingly, KDIGO in its guideline in 2020 said that SGLT2 inhibitors should now become the first-line drug in the treatment of type 2 diabetes with chronic kidney disease. Then comes the same patient which I alluded to earlier on, and if you again put on the heat map our new molecule finrenon, the non-steroidal mineralocorticoid receptor antagonist, we have three sets of studies or data, let us say. The Fidelio-DKD and Fidelio-DKD recruited patients with milder variety of kidney disease. The severe variety of kidney disease. And Figaro included patients with mild variety of CKD. And there was a pre-specified pooled analysis which is called Fidelity. So Fidelio, Figaro, and Fidelity, if you combine these three data, it basically tells you that any patient with type 2 diabetes with almost any level of eGFR and USCR will fit into the category of an approved criteria for using finrenon. And this is the robust data. Look at the data of the cardiovascular outcome and look at the data of the renal outcomes. Every single outcome that you talk about is favorably impacted by the use of finrenon. And this gives us a very, very important idea. How does it benefit? I talked about the reflection of kidney damage. And what is reflection of kidney damage? Increased urinary albumin creatinine ratio. And here you see a consistent reduction in the USCR, not only very robust, but on a very persistent way by using finrenol-like molecules. But if a new molecule is there, we must look at the side effects. And the side effects of finrenon are absolutely comparable to placebo. And therefore, it is very heartening that we don't worry much about the side effects. But any receptor antagonist, MR receptor antagonist, the risk of hyperkalemia will always be there. I told you about the half-life, short half-life. So hyperkalemia was marginally increased, but severe hyperkalemia leading to death was 0. And we actually can identify that which patient is likely to get hyperkalemia. To start with, if a patient's eGFR is very low, urinary albumin creatinine ratio is very high, and if the patient is concomitantly taking a beta blocker. These are 3 important risk factors which you identify right in the beginning, you will actually avoid the development of hyperkalemia. This is extremely important. This is a fine art study again using Finrenon, and every outcome, cardiovascular outcome, is favorably impacted. We don't need to go into the detail. This is the fidelity pre-specified pooled analysis that again shows the cardiovascular composite, the heart failure hospitalization, eGFR, the renal outcomes. The good thing is that SGLT2 inhibitors and Finrenon have singularly shown a statistically significant benefit in all the cardiovascular and the renal outcome. With minor hiccups here and there, that's a different thing. What if you combine the two, as I said, Amitabh Bachchan and Shah Rukh Khan together? Now, if you combine Finrenon and SGLT2 inhibitor, that's the additional benefit that you get. One data here, another data here, and this data is mind-blowing. This shows that Finrenon alone is good, SGLT2 inhibitor alone is good. If you combine the two, they are better. If you combine a GLP-1 receptor agonist on top of these, now brings Salman Khan also into the picture, then the 3 are better than the 2. So this actually gives you that now you have the Amitabh Bachchan, Shah Rukh Khan, Salman Khan, and Amir Khan, all 4 together. That's how now we treat chronic kidney disease in type 2 diabetes, and this is called pillared approach. On a background optimum use of RAS blockade, you use SGLT2 inhibitor, you use Finrenon, and you also give GLP-1 receptor agonist. But somebody from the audience can tell me what percentage of our patients can afford GLP-1 receptor agonist. They cost about 12,000 rupees per month. Finrenon costs 90 rupees per day. But then I can tell you from my experience that India is one of the biggest markets for these 2 drugs, Finrenon and GLP-1 receptor agonist. I write 1 Finrenon prescription every day. That's how, when I say कि 90 रुपए की गोली होगी लेकिन किडनी के लिए लिखना है, every patient tells me कि हाँ सर लिख दीजिए. Nobody refuses. Health is of supreme importance, and therefore I always reiterate in any medical conference that cost is a factor of time. Cost should not preclude your judgment towards the beauty of a molecule if there is robust data. Of course, if a particular patient cannot afford, then that patient will not take it. That's a different matter. Same, not only chronic kidney disease, the heart failure. Again, the heart failure on a background of beta blocker, ARNI, and aldosterone antagonist, you must give an SGLT2 inhibitor. And the beauty is that if you are treating chronic kidney disease with these molecules, they will benefit heart failure, they will give less heart failure, and if you are treating heart failure with these molecules, there will be lesser kidney disease. And not only that, these molecules will help each other in mitigating their side effects. Look at the wonderful synergy that we are talking about. So that's the beauty of these 2 molecules. And finally, when you come back to my first slide where I showed the metabolic factor, the hemodynamic factor, the factor related to inflammation and fibrosis, then the best way to treat type 2 diabetes to prevent cardiovascular outcome and chronic kidney disease is to use RAS blocker, to use SGLT2 inhibitor, to use Finrenon, and if the patient can afford, to use a GLP-1 receptor agonist. Ladies and gentlemen, if we believe in the science, if we believe in the data, and if we can, our patients can afford these 4 drugs, nothing could be better for a patient of type 2 diabetes for prevention of cardiorenal outcome. Thank you very much for your kind attention.
Now this session is open for any query or question or comment. Any comment or question from the audience side?
Again, it's a wonderful talk, multiple times I have listened. In fact, I have started my career with the first CME when I listened to you. And you have always been my most favorite speaker. Today also the same. Today we have seen 2-3 development. One, that India has gone a step up in its economy and now in fourth world economy instead of the fifth economy. Definitely it will have some impact on the affordability of the Indians, and maybe Indians may be more affordable for their health and and of course we are more aware of our health also. We always know that Indian population moves faster towards the end organ damage as compared to the rest of the world. Multiple reasons are there. We start treatment late, we don't care for the treatment, many a times we are not adhering to the therapy. But in such situation, when we are having a big population which is moving faster to the end organ damage, and because of what we are requiring a lot of tertiary care for our own population, is Finrenone kind of the medicine can help us? If yes, then at what level we should start using them?
I think this is a very important question, and my own perception is, but we will be needing data for that, that if a molecule is going to target inflammation and fibrosis, which is the fundamental pathogenetic mechanism, I don't see any reason why it should be delayed so long in the spectrum of that particular disease. So I totally agree with you that if we really want to make a salutary impact in reducing the cardiovascular and renal outcome, we should be giving these drugs very early in the natural history of type 2 diabetes. Affordability, cost, etc. And not only that, the ability to convince, forget about the patients, the ability to convince our colleague physicians that these drugs should be used in tandem right from the beginning is a big challenge. But if it can be done, it is surely going to benefit the patient.
When a patient is explained properly, yes, the cost of your treatment is costly. But if the complications develop, it will be 50 times more costly. If you develop CKD, how much the cost will be? If leg amputation occurs, what could be the thing? Blindness is there.
True.
Then the patient becomes convinced. We were earlier not in the habit of spending on health. None of the family has got the health budget. But as Anuj said, that ours is the fourth economy now, and we have got more affordability. Plus we are learning that in the later stage we will have to spend much more. So they are spending more initially also on the drugs.
We have to understand one thing. I am very much interested in politics also. We are the fourth or fifth largest economy in the world, but our per capita income is 142nd in the world. So let's not always rejoice being the fourth largest economy. It is the money distribution which is also very important. We rank 142 in the world in per capita income, which is very low. But then there is so much, lopsided distribution that even if 10% of the Indian population, 10% of 140 crore, think of it, 10% of 140 crore is a huge number. And that's where the pharmaceutical companies are preying upon India. Because 10% of 140 crore people is a lot of patients, more than what they get in the Europes and Americas. So that's how it works, yes.
So we need not forget the cheaper drugs too.
Absolutely, absolutely. If my patient cannot afford a GLP-1 receptor agonist, I will use a DPP-4 inhibitor, that's fine. SGLT2 inhibitor, if my patient cannot afford the original drug, I will use a generic drug. But whatever advantage I can give to my patient, I think it's our duty to do that.
Thank you, sir. So it was really a wonderful presentation regarding especially the Finrenone. If I combine Finrenone with SGLT2 inhibitors, definitely the study goes to regarding SGLT2 inhibitor in the pool, especially dapagliflozin. But I just want to know what is your personal take regarding Finrenone and empagliflozin combination.
Yeah. I don't ever advocate that any SGLT2 inhibitor is better than the other. It's a class effect, it's a class effect, it's a class effect. Empagliflozin, canagliflozin, dapagliflozin, they are all wonderful molecules. That's number one. So, any SGLT2 inhibitor is good. Regarding Finrenon combination, I have already given you the data. If you ask my personal experience, friends, I can tell you that now we have been using Finrenon for almost 1.5 to 2 years. And for the first time in my career, and because I have a very robust database and the follow-up is also very strong, we have 70% of our patients who are already there in our follow-up. So I can tell you for the first time, a patient with a serum creatinine of 1.6, 1.7, up to 2.2 to 2.3, we have seen reversal of kidney damage coming back to a normal serum creatinine level. That is something which we never saw even with SGLT2 inhibitor. This is for the first time since we have started using the Finrenon, we can see a reversal in the serum creatinine level from a fairly advanced stage to a normal stage. That never happened earlier upon. This is my personal experience. We can collect the data on this in a bigger way under the platform of RSSDI through our research team.
One question, sir, Ajay sir. I am using this Finrenon for last 1 year. My patient, what is my personal experience is that nearly 10% of the patient develop hyperkalemia. And that's why I have to send the patient to the further other tertiary care center. I don't know why the data is showing that the Finrenon has less hyperkalemia. But
I will tell you, if I'm not taking a lot of time, there are so many speakers. There is a rule of monitoring serum potassium when you start Finrenon. I don't know whether you are doing that. If you do that, never any catastrophe. That's what I exactly do. When you start Finrenon, then after 2 weeks, you must check the serum potassium level. And if serum potassium level is high, high means more than 5.5, then you have to stop it. And stop it doesn't mean that you will not use it in future. Stop it briefly, as I said, because there's a short half-life. The second mistake which people do is that they are patients of heart failure also, so they are taking aldosterone antagonist, Ditor plus, Tide plus, right? And you add Finrenon. You are doing a disaster. That polypharmacy is a disaster. You are using mineralocorticoid receptor antagonist along with a non-steroidal receptor antagonist. That's where the serum potassium goes up. You are using RAS blockade plus Finrenon, and both of them increase the serum potassium. So you have to keep a close eye. If you follow the guideline tells you after 2 weeks, then 4 weeks, and then every 4 months. If you monitor the serum potassium, never ever any problem will occur with Finrenon. In my 2 years of experience of using Finrenon, it has not caused any problem with hyperkalemia.
Thank you, sir. Thank you so much. It was a very wonderful session. Due to lack of time, we must conclude the session. Thank you, sir. Thank you so much.
I request our chairpersons to please felicitate the speaker. I also request our speaker to please felicitate the chairpersons. Next, we have an interesting case discussion on gestational diabetes mellitus, for which I request Dr. S.N. Jha sir, Dr. P.M. Srivastav sir, Dr. Shashi Prabha ma'am, and Dr. Richa Raj ma'am to kindly come up on the stage to chair the session. The case will be presented by Dr. Nazia Parveen, postgraduate student in the Department of Obstetrics and Gynecology at DMCH.
इस स्लाइड पॉइंटर जी इससे भी कर सकते हैं, इससे भी कर सकते हैं।
Good evening to my respected sir, ma'am, and my colleagues PG. My name is Dr. Nazia Parveen, third year PG of Scanning Department. Today my topic's case presentation of gestational diabetes mellitus. So my patient is Soni Kumari, 20 years, females, G2P11, with occupation she is a housewife, a resident of Bahadurpur, came on DMCH OPD with a 26-week period of gestation. Chief complaints: patient came for routine prenatal visit with an incidental finding of elevated blood glucose level on screening. So other patient's symptoms is not reported. History of presenting illness: patient presented for her routine antenatal checkup at 26 week of gestation. As a part of the standard prenatal screening protocol, an oral glucose tolerance test was performed at 24 week, revealing abnormal glucose level suggestive of gestational diabetes mellitus. There is no symptoms of the patient is complained. There is a polyuria, polydipsia, and no history of previous gestational diabetes mellitus in her first pregnancy. History of present pregnancy: in first trimester scan was done, which was normal. After spontaneous conception, the patient taken folic acids properly. Second trimester, patient ultrasound scan also done, which were also normal. Oral glucose tolerance test concluded high sugar level, which is 150 milligram per dl. And patient is completely immunized with taken iron, folic acid, and calcium tablet. The past medical history is not relevant. Obstetrical history: G2P1L1 patient, first pregnancy 3 years ago, full-term normal vaginal delivery, healthy male baby, birth weight 3.2 kg, no complication reported in previous pregnancy. And family history: father has type 2 diabetes mellitus, which managed with the oral hypoglycemic agents. Personal history: patient is sedentary lifestyle, minimum physical activity, and drug history is no drugs allergy, but prenatal vitamins like iron, supplementals, folic acid are prescribed to the patients. Physical examination: on general appearance, patient is well-being, no distress. On examination, pallor, icterus, and clubbing, lymphoadenopathy, edema, which are absent, and vitals are stable. Patient BMI 26.6 kg per meter square. Per abdominal examination of this patient, fundal height is consistent with 26 week of gestation, which normal FHR, that is 140 beats per minute. This is regular FHR. On laboratory investigation of these patients with oral glucose tolerance test with 75 glucose, the fasting blood sugar level, that is a 98 milligram per dl. After 75 glucose with 300 ml of the waters given to the patient, and the check blood glucose level at 1 hour, that is a 190, and 2 hours, that is a 160 milligram per dl respectively. And one value above the threshold, that is a diagnostic of gestational diabetes mellitus. Others report of this patient, that is HbA1c, RBS, CBC, thyroid function tests, routine urine examination, these are normal. USG also normal, which shows normal fetal growth, no evidence of polyhydramnios, macrosomia at this stage. So, above the report, based on the oral glucose tolerance test, patient is diagnosed with the gestational diabetes mellitus. So, management plan of this patient focus on achieving euglycemia to minimize maternal or fetal complication. The approach is multidisciplinary, involving the obstetrician, endocrinologist, dietitian, and diabetes educator. So, first line of treatment of this patient is a medical nutrition therapy with properly a moderate type of exercise. In medical nutrition therapy, we require the macronutrients like carbohydrate 40 to 50%, 20 to 25 25% protein and 30 to 35% fats. With patient is also low glycemic index food, high fiber, and small frequent meals, as for example 3 meals for 2 to 3 snacks per day, and avoid the refined and sugars and processed foods. So, a goal of medical nutrition therapy is maintain the blood glucose level within target ranges. The target ranges of this glycemic control of the patient, fasting is 95 milligram per dl, and after 1 hour PP is 140 is less than, and 2 hour PP is less than 120 milligram per dl. So, physical activity, brisk walking for 30 minutes daily, moderate, that is a moderate exercise, unless contraindication is not indication. And because moderate exercise which causes the insulin sensitivity and glucose uptake. So self-monitoring of blood glucose is also done to this patient. Advised to monitor blood glucose level 4 times daily. That is before the meal, after each meal. Glucometer provided with instruction for use, and weekly follow-up to review the glucose log. And pharmacological therapy is needed. If glycemic targets are not achieved with medical nutrition therapy and exercise within the 1 to 2 weeks, then pharmacological intervention will be considered. In pharmacological interventions, we consider the short-acting insulin. If blood glucose is not controlled with the short-acting insulin, then long-acting insulin or basal bolus insulins can be added to the patient. The patient preference or assess issues and insulin is not feasible, then oral hypoglycemic, that is metformin, is considered to the patients. Fetal monitoring also important of this patient with regular ultrasound to monitor the macrosomia, polyhydramnios, and fetal growth proper horakine. And also test for non-stress test is also starting the 32 to 34 week if glycemic control is suboptimal or complication also present. So this patient is a counsel on this risk of to educate the counsel the risk of progression to diabetes mellitus, because 30 to 50% risk after post-delivery within 5 to 10 years. Follow-up plan. Weekly antenatal visit with self-monitoring blood glucose review. Repeat oral glucose tolerance test at 6 weeks postpartum to screen the persistence for diabetes. Lifestyle counseling with regular physical activity, balanced diet, and delivery planning to this patient is if glycemic control is good, then the delivery at 39 to 40 weeks. If poor glycemic control, if a macrosomia baby, then the delivery at 37 to 38 weeks, and mode of delivery is vaginal delivery preferred unless obstetrical or fetal indication are for cesarean section is not indicated. So above the universal screening which occurs, which is done as 24 to 28 week, using 75 oral glucose tolerance test is recommended by WHO, American Diabetes Association. High risk women अगर आ रही है तो that means कि screening first trimesters में करेंगे उसका. And diagnostic criteria according IDPSG WHO, fasting is greater than 92, 1 hour 180 and 2 hour 153 milligram per dl. अगर ज़्यादा होगा तो that means कि diagnostic है कि gestational diabetes mellitus है. So conclusion is my patient G2P1L1 and 26 week of gestation diagnosed with gestational diabetes mellitus based on oral glucose tolerance test result. She has been started on the medical nutrition therapy and self-monitoring of blood glucose with a plan for the close follow-up. The goal is to achieve euglycemia to minimize the fetal or maternal complication with insulin as a next step if needed. So postpartum screening and lifestyle intervention will be critical for long-term health.
Nice presentation by Dr. Nazia. As you well know, monitoring and treatment of gestational diabetes is very difficult because effect of hypo and hyperglycemia on the fetus is there. So be careful in the treatment of gestational.
Thank you.
What is the contraindication of metformin?
Yes, ma'am. Sorry, ma'am.
What is the contraindication of metformin? Metformin can be used
Okay,
in pregnancy.
ma'am, metformin drugs which causes GIT symptoms, also metabolic acidosis. और अगर renal function disarranged है मैम या metabolic disorder है patient को तो that उस condition में हम नहीं करेंगे. और GIT का symptoms patient को बहुत ज़्यादा हो रहा है मैम तो उस condition में भी metformin is contraindication होता है.
What is the other long-acting insulin?
Ma'am,
drugs?
Galergine is long-acting or short-acting is Lispro, Aspartate.
Why the dose of insulin is increased during pregnancy? Why it's needed during pregnancy?
Ma'am, during pregnancy, fetus requirement for glucose is increased, which depends on the maternal blood glucose. So, in fasting condition, the fetal mother is hypoglycemic. If अगर हम blood glucose level करते हैं, तो then mother का जो report आता है वो hypoglycemic आता है क्योंकि fetus जो है वो totally dependent है mothers के blood glucose पे. Then postpartum condition में अगर हम report देखते हैं, तो उसमें glucose का level increase होता है. Because it occurs due to insulin resistance, ma'am.
Pregnancy, low-grade inflammatory conditions, जिसमें CRP and IL-6 increase करता है, जो insulin resistance को increase करता है, जिसकी वजह से glucose का dose, insulin का dose increase करना होता है.
Yes.
What is the effect of diabetes on pregnancy?
Ma'am, it causes the fetus, maternal and fetus and neonatal also complication. In case of diabetes agar hoga, तो then ma'am अगर gestational diabetes और other diabetes which are criteria in divided into and अगर gestational diabetes matters होता है मैम तो baby macrosomia baby हो सकता है mothers को polyhydramnios की वजह से preterm labor premature ruptures of the membrane और plus और साथ में atonic PPH में भी patient जाती है due to polyhydramnios की वजह से और मैम ये patient preeclampsia में भी जा सकती है patient most commonly macrosomia ही baby birth करती है अगर वो IUGR के साथ अगर आ रही है that means कि PIH है मैम तो preeclampsia pregnancy induced hypertension हो सकता है और जो fetus है मैम तो abortion का chances हो सकता है still birth हो सकता है या बेबी में मैक्रोसोमिया होगा तो सोल्जर डिस्टोसिया ड्यूरिंग डिलीवरी हो सकता है और आफ्टर अगर हम बर्थ अगर हम बात करें तो न्यूनेट्स में मैम क्योंकि प्रीमेच्योर बेबी होता है तो इसमें रेस्पिरेटरी डिस्ट्रेस सिंड्रोम्स हो सकता है हाइपरबिलिरुबिनेमिया हो सकता है मैम.
Thank you very much for delivering a nice talk.
Just I want to add few more things that ma'am was asking. Pregnancy itself is an insulin resistance condition. That's why the dose of insulin usually increases. Number one. Number two, as far as metformin is concerned, we can judiciously and liberally we can use metformin also. Not there are so many contraindications, but we can use liberally and judiciously. So our fellow speakers they will throw more light on that.
Okay, sir.
So that
early pregnancy as soon as possible after delivery of the. Yes, ma'am.
Thank you.
Very nice presentation. Thank you.
I request our chairpersons to please felicitate the speaker. To felicitate our chairpersons, I request Dr. Hari Damodar Singh sir to please come up on the stage. For the next session, I request Dr. UC Jha sir, Dr.
Hyperglycemia in pregnancy is such a condition which, if not treated, will cause damage to both mother and fetus, and if treated, will give benefit to both mother and fetus, not only during the presenting pregnancy, but also after parturition and after a long time to come.
थैंक यू सर, आपने अनुज सर का बहुत ही ज़बरदस्त इंट्रोडक्शन दिया, लेकिन आज RSSDI बिहार में
RSSDI is an organization of 12,000 physicians in India. And this is the largest organization of the Asia and second largest organization of the world after the IDF, which is having so many members, physicians or diabetes practitioners, endocrinologists in this. And this is dedicated to the research. But majority of the research, what is being done on the platform of the RSSDI, participation of Bihar, Uttar Pradesh and our northern state has not been much. And you can understand by simply this thing that Uttar Pradesh is contributing 20% population of the country, largest state of the, and I am the second person from Uttar Pradesh who has been the RSSDI president. And I don't know whether anybody from Bihar have been or not. I think nobody have been before. So this is very much important agenda before us. How can we increase the interest in the physicians, in the diabetologists, in the endocrinologists of the Bihar as well as Uttar Pradesh to contribute more towards the RSSDI affairs as well as more towards the research on the platform of the RSSDI. 2-3 kinds of the research usually being done. One is research which is a structured research, what we do in our colleges, and we ask the RSSDI for the research grant. RSSDI gives lakhs of rupees research as a research grant every year, so you can also ask for that research grant, submitting your proposal. Second thing is that we have also started some of the things and some specific topics which we give from the RSSDI and request to our members to submit the data on our portal of the RSSDI.in. Like after a few days we are going to start 10 into 10 challenge of hypertension in patients with diabetes, in which we are targeting 10 lakhs patients of diabetes to be checked for their blood pressure, and it's to be recorded at the RSSDI website by many of the physicians. And in this we have kept that 50 largest contributor shall be given the advantage of being author in the paper. Next 100 largest contributors shall be acknowledged as a contributor, and then 150 plus those who have already acknowledged as contributor and author will be given the certificate of the champions of hypertension in diabetes 10 by 10 challenge by RSSDI. So these are the things, and every contributor, even if you are giving 20, 30, 40 patients in this activity, will be given a participation certificate. So this is a very good opportunity for the postgraduates to earn the certificate from the RSSDI. If you can submit a good number of the patient, you can have champion certificate. Otherwise, definitely you are going to have the participation certificate. Another important activity we are going to start, that is the rural diabetes care. And both the activities are just going to start in the Bihar also. Tomorrow we are going to start the rural outreach program in Bihar. So with these information, I would like to increase my slide and take you to the another very much important information. That is our annual conference. This year our annual conference is in Kochi. Kochi is a very good and very scenic place. So all of you are, especially the postgraduates, are requested to submit your abstract for the Kochi conference. And I am the scientific chair. I will see that as much as possible people from our state could be accommodated as a presenter in RSSDI Kochi. So please do submit your abstract there and be participant there. So this is my request to all of you. Get yourself registered, get yourself submitting the abstracts, and be participants of the RSSDI Kochi. Now come over to the topic. very nicely a case has been presented just now. One thing would like to highlight it here, whenever we should present a case, the identity of the patient should not be disclosed. So what I could see there that postgraduate who was presenting, she has written the name of the patient. Never disclose the name of the patient in any case report or in any case which is being presented at the public platform or social platform where multiple people are listening. Always you can use like Suraj Kumari, you can use SK. Whatever the initial, that should be used. Rest of the things we shall also come up when the presentations would be going on. What is the gestational diabetes and how it is different than hyperglycemia in pregnancy? Hyperglycemia in pregnancy is a condition where we know that patient is having the type 1 diabetes or type 2 diabetes and entering into the pregnancy. Gestational diabetes is that which develops in the pregnancy when the pregnancy has already been started. But what is common between those two things? The first is known diabetes, and second category which is going to develop gestational diabetes, she is more inclined to have the diabetes, and maybe in the next 10 to 15 years, very rightly mentioned by the postgraduate, that 35 to 50% women, those who develop GDM, become type 2 diabetic in next 10 to 15 years. So she is going to be type 2 diabetes. So this is the opportunity where we can stop that lady to become diabetes. Not only that lady to become diabetes we can stop, but also we can stop the next generation to become diabetic. Because if we can control her glucose level in this pregnancy, she can be stopped to become diabetic in the next 10 to 15 years. At the same time, the baby who will be born to that lady will not become more inclined to become diabetic. Pregnancy is the only state across the life where insulin resistance is a welcome step. Insulin resistance is a necessity. Why it is necessity? Because of that insulin resistance, whatever the mother eats, that is transferred to the placenta and helps in development and progression of the baby. The layer of the fats and layer of the muscles has been formed because of that nutrition which is being transferred from the mother to the fetus because of the continuously increasing insulin resistance. So insulin resistance is actually a boom, and whenever this insulin resistance is not there, then we develop so many situations like many a times fetus dies early in the pregnancy and so many other things happen, which we will be discussing here. So if we wish to reduce the insulin resistance in the early days of the pregnancy, of course, it can help in reducing the macrosomia, it can help in reducing the development of whatever the fat deposition is happening in the baby inside of the womb. But at the same time, we should be ready to face the risk of the malformation of the fetus, risk of the fetus which may develop his abortion, and we may have this kind of the situation. Many a times we get the early jaundice when the fetus is born. So manifestation of the glucose intolerance in the pregnancy, often named as the gestational diabetes, in emerging as a major public health problem. So what is the glucose intolerance? Normally, out of the pregnancy, we consider if the glucose level between 140 to 200, it is called as glucose intolerance. But if it happens in the pregnancy, then it is called as gestational diabetes. If any lady during the pregnancy is keeping her glucose 140 and more or more than that, she is called as gestational diabetes. Between 120 to 140 we call as the gestational glucose intolerance, or we can say gestational prediabetes also. So according to the IDF, global prevalence of the GDM is 19.7%. Meta-analysis of Mantri et al. Has estimated the prevalence of GDM in India, which is 13%. So 19.7% is the world prevalence and 13% is the India prevalence. As we all understand it very well, if the hyperglycemia continues in the pregnancy, then it makes the person not only to become diabetic in next coming future, some become just after the pregnancy diabetic, some becomes after few years, and some may take 5 to 10 years to become diabetic. But there is definitely a risk of getting type 2 diabetes in the women as well as in the forthcoming child. That women may have the preeclampsia. Macrosomia again is step towards the type 2 diabetes in the next generation. Because of the macrosomia, chances of the cesarean section would be more. Ovarian dysfunction, neonatal jaundice, maternal depression, breast cancer, and other reproductive disorders are always on the card because of the hyperglycemia in pregnancy. So screening recommendations which are done by the organization like IADA, PSG, ADIPS, NICE and ADA, and DIPSI. DIPSI is the Indian organization. IAD PSG recommendations for the screening has already been told by the postgraduate who has presented the case. Fasting plasma glucose 92 or more than that in early pregnancy should be the diagnostic. ADIPS says that risk-based early OGTT screening is recommended. NICE and ADA, American Diabetes Association, NICE is the UK body, risk-based screening at the booking of the early visits. Diabetes in Pregnancy Study of India says that early screening in India since 2006 is recommended. Universal screening because Indians are always on the higher risk. So as the recommendations what you said for the gestational diabetes diagnosis, 24 to 28 weeks, which is the conventional recommendation and which is written in the book. But problem is that if any lady develops hyperglycemia at 10th week or 12th week, and we are going to check it on a 24th and 28th week, then we are keeping her harm with the 12 or 14 weeks of the hyperglycemia. 12 and 14 weeks of the hyperglycemia is going unnoticed, which is causing harm not only to her own and organs, but also it is giving rise to the risk to child. And what happens? Because at the 12 weeks of the gestation, pancreas is formed. So hyperglycemia, if it is being there, then it is continuously stimulating the fetal pancreas, and fetal pancreas is getting more and more insulin secreted. So two things are getting there. One, it is getting more and more insulin secreted. So whenever the child will be born, then chances of the recurrent hypoglycemia would be more. And second thing is that pancreas or beta cells are going to be exhausted early because of the excessive work they are being done, and maybe the possibility in the 12 years or 13 years or maybe in the early age that child may develop type 2 diabetes. Maternal risk of the GDM, well known to all of you. Short-term risk could be the dystocia, miscarriage, eclampsia, preeclampsia. Long-term risk could be the 10 times higher risk of developing type 2 diabetes. There may be more risk of the developing cardiovascular disease, and recurrent GDM in the future pregnancies is another risk which may occur if we do not control the glucose in the present pregnancy. Delivery complications may be the higher cesarean section rate, postpartum hemorrhage, and intrauterine infection. The risk what can occur in the offspring which is going to take birth, of course macrosomia, we have already discussed that. Neonatal hypoglycemia, just I told you. Respiratory distress and hyperbilirubinemia, neonatal jaundice. These are the things which may occur in the child which is going to take birth after the hyperglycemic pregnancy. There has been done a prospective study in 10 to 14-year-old children showed that the offsprings of the mothers with untreated GDM are at a higher risk of the impaired glucose tolerance. Among mothers with GDM, 10.6% of the children had impaired glucose tolerance, whereas only 5% of the children of mothers without GDM had the IGT. So if a lady is having the gestational diabetes which is not controlled and which is not brought to the desired level of the blood glucose, then she develops, then the offspring which is taking birth from her having that 2 times chance of developing impaired glucose tolerance as compared to the children of that lady who is not developing GDM. So developmental origins of the health and disease, if we talk about the concept of developmental origin of health and disease reflects how conditions during pregnancy can program health outcomes throughout life. Maternal hyperglycemia creates an intrauterine environment that influences the child's metabolic system, potentially leading to hypertension, obesity, and diabetes later in the life. So what should be the current GDM detection approach? Traditional screening, what is suggested to us and what is written in book is 24 to 28 weeks of the gestation. Use several methods from 2-step to the single test approach. Multiple organization has suggested multiple methods. DIPSI in India says that single test is enough if any time without looking for that whether the patient has taken meal or not. Timing challenge, late detection limits the intervention opportunities. As I already said, if we are not doing it appropriately, earliest if we are not detecting, for example, if lady is developing the hyperglycemia at the 10th week or 12th week, and we are going to check at the 24th to 28th week, so we are losing the opportunities of the intervention. Delayed interventions may fail to prevent the GDM complication. So there are the 2 different categories of the GDM, what we understand. One is the conventional GDM, what we call it after 24 to 28 weeks, which is being diagnosed, and we are treating with the insulin and sometimes with the metformin or combination of the insulin with metformin. But there is another category which is being developed and being recognized across the world, that is the early GDM. Hyperglycemia detected in the first trimester or before 28 weeks of the pregnancy is called early GDM. And prevalence varies 0.7% to 36.8%. Associated with the greater insulin resistance, lower beta cell function, higher BMI and metabolic syndrome markers could be there if it is not well treated and well taken care in time. Metabolic profile of the early GDM. Because why does this early GDM occurs? Why does it happen? Because the lady who is developing the early GDM having beta cell dysfunction, which is more than the other ladies who are developing at 24 to 28 weeks. Triglyceride is level high. Blood pressure readings may be elevated. Insulin resistance has started growing very high since from the very beginning. A higher BMI, increased body mass index, waist circumference is larger in the women, those who develop in early GDM. Why look for the early GDM? Because this is an opportunity to early intervention so that the earlier appearance of the fetal growth abnormalities could be stopped by screening in this window. Abdominal wall thickness, like increased thickness in the South Asian fetuses, which are exposed to the early GDM. This is another thing which has not been thought by many of us. Early screening needs especially important in high-risk ethnic group like Indian Asian. Clinical outcomes of the early GDM. If we do not treat the early GDM, what will happen? Of course, the chances of the preterm birth, fetal loss, neonatal jaundice, larger birth weight or macrosomia are on the card. Postpartum risk could be the higher risk of the developing type 2 diabetes, greater need for the insulin treatment, more of the metformin requirement, and early treatment critical to reduce the risk, and monitoring throughout the pregnancy helps us. Postpartum follow-up is essential. There has been a TurboGM trial. In this trial, large randomized control study has been done, which has been conducted across the multiple countries, including India. It has compared early diagnosis and treatment of the early GDM to the usual care. Significantly reduced adverse neonatal outcomes with early intervention. Some pregnancy complications like hypertension showed no significant difference. Now question arises, how should we go for the monitoring? What is the current monitoring trend? What was being suggested as of now, we used to say to our mothers or prospective mothers to check your glucose level by self-monitoring of the blood glucose by 6 times or 7 times in a day, which is the traditional finger stick method requiring multiple daily samples. But limited data points captured throughout the day, and many a times most of the females are not ready and not inclined to do this kind of the multiple pricking. So we have the continuous glucose monitoring system for that. CGM is boon for the gestational diabetes, in which we get the real-time or intermittently scanned subcutaneous sensors, which provides comprehensive glucose fluctuation data. HbA1c or glycosylated albumin are also being tested or being used, but they are not so much reliable during the pregnancy for multiple reasons. So we talk about the CGM technology. There are the subcutaneous sensors, which could be waterproof, self-administered devices placed under the skin. Wireless transmitters are there. Data analysis system is also foolproof, in which we generate comprehensive glucose profiles and identify patterns invisible to the traditional monitoring. CGM technology provides continuous insights into the glucose levels without painful finger stick. So while doing the CGM, you can also understand and you can also know what is going to take place after 1 hour or 2 hours, what could be the prediction of the glucose in next 2-3 hours also. So real-time CGM system and intermittently scanned CGM, these are the two available options are there. Real-time CGM system does the continuous monitoring, which measures glucose every 5 minutes for 3 to 14 days, and real-time data displays the current glucose values and trend the directions. So when it trends the direction, it can tell you that next 1 hour or next 2 hours, you are going to have the hypoglycemia or you are going to have the hyperglycemia. Alert system is always there, which gives you a warning with a beep. So provides warning for high and low glucose events, creates glucose trend analysis for 24 hours. On the other hand, the intermittently scanned CGM, which is a wearable sensors applied to the upper arm, users and data is retrieved and demanded by the scanners, and many of the times detects previously and unidentified nocturnal glucose excursions, records between the scan. So it has got the benefits of the comprehensive analysis across the 24 hours. There is an alarm which prevents hypo and hyperglycemia events. Nocturnal monitoring becomes easier because in the midnight, most of the time, many females develops the hypoglycemia, which can easily be detected by these CGM techniques. It improves the compliance, also reduces finger stick pain, and provides ambulatory glucose profile with trend arrows for intuitive data interpretation. As far as the early interventions are concerned, CGM can identify patients who need medications earlier than traditional methods. Every 1% increase in time above the range, TAR means time above the range, increases probability of requiring drug treatment by 24%. What do you mean by the time above the range? In 24 hours, whatever the time a lady is spending in the desired level of the glucose, means what is the desired level of the glucose? Between 70 to 180 is the desired level of the glucose. If she is spending in this window, that is called as TIR or time in range. If it is more than that, it is called time above range. If it is less than that, it is called time below range. So if every 1% increase in time above range increases the probability of requiring drug treatment 24%. 1% means if it is at the 180, if we are going to have 182, the chances of the 24% drug treatment are increased. Complication prevention, early intervention reduces the risk of macrosomia and other complications. Personalized management, data allows for individualized treatment plans based on the specific glucose pattern. So here very easy to understand. At 12 weeks of the pregnancy, if a lady develops the hyperglycemia and we do the intervention at that time, then probably we can stop the development of the macrosomia. And we can stop the development of the macrosomia, so we are going to have the lot of prevention of lot of problems. We can stop the diabetes or glucose intolerance in that fetus which will be taking birth, we can stop the recurrent hypoglycemia. At the same time, we can reduce the probability of cesarean section in that particular women. I don't know whether the gynecologist would like it or not to reduce the probability of cesarean section, but it can be. So recommended CGM use duration, like standard recommendations are for 14 days of continuous monitoring for the comprehensive assessment. In type 1 diabetes, we say that 12 to 15 days every 3 months for accurate glucose control should be used. For pregnancy, continuous use throughout the pregnancy for optimal monitoring is recommended. Data collection for minimum 10 days of the data for reliable glucose pattern analysis is enough. So key CGM indicators, as I already said, 3.9 to 10 millimole means 70 to 180 milligram per deciliter is the target TIR, time in range. When it is less than that, it is called time below range, and when it is more than that, it is called time above range. So there has been a new study in which 107 women from 2 Sydney hospitals participated. Participants were blinded to the CGM for 7 days and then completed OGTT. Participants tracked the diet and exercise and completed questionnaire on the risk factor. 87 women, which were the 81% of the 107, had valid data for the final analysis. 87 women were included from 107 recruited, that was the 81%. Most exclusions are due to the CGM recording period less than 7 days. 74%, which are 74 participants, means 85% had normal glucose tolerance. 13 were having the GDM via OGTT. GDM group more likely to have family history of the diabetes. 54% were having the family history of the diabetes as compared to the 23% those who did not develop. So lower average glucose, we could see the improved maternal outcome in this meta-analysis of the 482 patients showed reduced mean glucose level with use of the continuous glucose monitoring system. Maternal weight gain could also be checked by using the continuous glucose monitoring system. The study has also shown that 100 GDM patients showed higher insulin sensitivity in the CGM group. And this provides a stable glucose monitoring that improves the maternal outcomes compared to the traditional method. So what could be the future directions in this? Better integration with the insulin pumps for the closed loop system we can look for, especially in the pregnancy, because pregnancy is the condition where multiple shots of the short-acting insulins are required, especially in the GDM. Chances of going into the hypoglycemia are more because the window of normal glucose or window of the desired glucose is very small. Because of what we need to check on the hypoglycemia, which is always remains on the card, and insulin pump plays a very important role there. Continued improvements in the sensor accuracy and reliability is again improving and indicating the use of the CGM. Increased availability and affordability for all pregnant women with diabetes. Advanced predictive algorithm for early intervention. Identify the high-risk patient who would benefit most from the continuous glucose monitoring system. Provide through training on the device use and data interpretation, and we should schedule frequent data reviews to optimize the treatment. So primordial prevention concept, current generation, immediate benefits to the mother and child. Next generation reduces the metabolic disorders coming up into the offsprings or the new children which are taking birth from the GDM mothers. Population level, we can have a long-term reduction in diabetes prevalence. Detection, especially in the first trimester, if postprandial blood glucose level is tested between 8th and 9th week of the gestation, identifies women at the risk of the GDM development. If it is 108 or more than 108, the chances of development of the GDM in the next few weeks could be very high. Medical nutrition therapy and lifestyle modifications are required to be started at that time only. Metformin when indicated for high-risk cases, regular blood glucose testing throughout the pregnancy and adjustments of the interventions as needed. I heard that postgraduate who was presenting the case, she said that glyburide or glibenclamide should not be used for the reason of the hypoglycemia. But actually this is not, because insulin is the strongest drug which can cause the hypoglycemia. Actually glyburide and glibenclamide is not used because it crosses the placenta, and that's why we don't prefer to use this. Metformin also crosses the placenta, but it has been found safe while using in the GDM, especially in the setting of the increased insulin resistance. In Indian perspective, Indian peoples are having high insulin resistance, so even in the early station of the metformin does not cause any adverse impact. Effectively lowers the postprandial blood glucose level to below 110 within 1 to 2 weeks, correcting intrauterine glucose imbalance. As far as the safety profile is concerned about the metformin, it has been proven safe and effective for managing GDM with established use in pregnant women with PCOS. Reduces the risk associated with macrosomia, preeclampsia, while decreasing the rate of the GDM and adverse neonatal outcomes when given in early pregnancy. So metformin, earlier it was thought that it should be started only after the 20th weeks of the pregnancy. Now the current concept says that you can start in the first trimester in early pregnancy also. So timing for the metformin intervention. 8 to 9 weeks of the gestation is the optimal timing for initiating metformin therapy in high-risk women with elevated postprandial blood glucose. Time typically needed to achieve the target glucose level below 110, or we need to go down to 92 in 1 to 2 weeks. Throughout the pregnancy, continued monitoring and management to maintain glycemic control. So once metformin is started, it should continue throughout the pregnancy, and assessment of the maternal metabolic health and infant outcome should be done even in the postpartum period to continue for that. Always remember metformin is being secreted in the breast milk also. So if you are continuing metformin in the postpartum period, definitely the child is also getting some part of that. So key takeaways of this presentation. Early detection is critical. First trimester postprandial blood glucose testing between the 8th and 9th week of the gestation offers a promising strategy for identifying GDM risk early. Lifelong benefits may be the early management of the hyperglycemia can improve long-term health outcomes for both mother and child, potentially breaking the cycle of the metabolic disorder. Timely intervention actually works. Early medical nutrition therapy, metformin, when needed, can significantly decrease GDM and its complications during the pregnancy if it is instituted at appropriate time, earliest possible. So ongoing research is already going, but still it is continued to be more and more, while promising more research is required to establish a standardized protocol for early screening and intervention across the diverse population. Thank you very much for your kind listening. Before I ask you to have any question if you have, I must tell you this very important data collection project of RSSDI, which we are going to start from 30th of this month, in which we shall be collecting the 10 lakhs people with diabetes, blood pressure data in 10 days. And this portal is live now for the registration. Members of RSSDI can get themselves registered. Those who are not member but want to participate in this activity, they can become the member. Postgraduates are having the discounted rate of the membership, only 6,000, they can become the life member. 25th May, earlier the day which we have started, but we are giving some more time to get registered for this project till 30th of May, and it will continue till the 10th of June. So you all are welcome to be a part of this campaign so that we can know about what is the situation. Also the pregnant women can also be screened for that. GDM has also been kept. Pregnant women can also be screened for their blood pressure if they are having the diabetes in their background. So thank you very much for your kind listening.
Thank you, sir, for your informative session. Sir, I wanted to ask you a question. How do we give insulin during labor? Are there any guidelines for that?
In labor?
During labor. How do we start and at what?
If we are treating a gestational diabetes patient, mostly as the labor starts, insulin requirement goes down very fast. And mostly it may not be needed sometimes as the labor goes on. But if we are treating a lady who is having the hyperglycemia of the pregnancy or having the type 2 diabetes or type 1 diabetes, then we need to give the insulin. And what is the protocol of that? If glucose level is ranging between 90 to 120, then we don't need to give any insulin. We can continue with the simple IV drip. If it is more than 120, then we should add 2 units of the insulin in per 100 ml of IV fluid. Mostly preferred is the normal saline. And if it is more than 160, then we give 4 units per 100 ml of the IV fluid. If it is above 200, then we
can
go
use a
with
sliding scale.
But it is not the exact, because many of the times, as per the insulin resistance, this can be changed also. So if a lady is having more weight, is having the bigger body, having obesity, then probably the insulin resistance may be higher for her. So it may be needing 4 units or 6 units even at the 120 to maintain at the 120 if it is ranging less than 140 also. But it is the starting dose. You can begin with this and these
Till
positions.
120 it is not needed.
Pardon?
Till 120 it is not needed. Insulin is not needed.
No, what is not needed?
Till 120.
Till 90 to 120 is the recommended, not needed. If it is less than 90, you need to reduce if you are giving.
Yes,
but if you are not giving, then you don't need to give till 120.
Thank you, sir.
Any question from the floor? Yes.
Sir, my question is, during your presentation, you told that HbA1c is not a reliable predictor due to multiple reasons. Can you tell me what are the reasons?
In gestational diabetes, I am telling you. There are 2-3 reasons for that. One is that in gestational diabetes, it starts once the pregnancy has already been started. So maybe at the 12 weeks or at the 15 weeks or 16 weeks. So what the HbA1c measures, that measures the previous 3 months glucose or previous 28 weeks glucose, which has already been passed. So you will not get the correct information if the gestational diabetes is developing today, if you are going to measure the HbA1c. Of course, you can get some high HbA1c if you will measure after the 3 weeks of the development of the gestational diabetes. For example, 24 weeks today, a person has been screened, lady has been screened, she found to be having hyperglycemic. If you will check the HbA1c, maybe it shows 5.8, 5.6 and 5. Less than 6. But if you check after the 3 months of that, after 8-9 weeks, then probably if she is not kept control, she has not been given the intervention immediately, then you can find the HbA1c going up very fast. Second thing is that blood volume changes during the pregnancy. So most of the time, the things which are being testing the previous 3 months are physiology of the women during the pregnancy gets changes, and it's very fast changing the RBC counts also. RBC's formation is also being changed. So that's why HbA1c is not considered as reliable. Although glycated albumin has been kept up to some reliability, but because of the GDMs is not giving the history of the hyperglycemia, so that's why glycated albumin also does not give you more correct values whenever it is being done. Pardon?
Is there something to do with RBC survival during pregnancy?
During pregnancy, RBC survival remains different in the individual, and that also remains the reason because of what HbA1c doesn't have that reliability. I'm just telling you, because of the change in physiology of the body, because of the change blood volume, and because of the change life expectancy of the RBCs, we don't take the HbA1c as a reliable to check for the hyperglycemia.
One question from my side, Dr. Anuj. In the early gestational diabetes mellitus, are 100% of them early gestational diabetes, or maybe a major section is pre-gestational diabetes or other forms of diabetes?
Yes, that is also a very good question, and we should always look into that. How can we really test this? At 12 weeks, if a person is found to be having hyperglycemia, here the HbA1c could be beneficial. If you check the HbA1c at 8 weeks or 10 weeks, if a person is getting, a lady is getting the hyperglycemia and HbA1c is high, then you can think that she is carrying the diabetes before development of the pregnancy. But if it is not high, if it is not more than 6, less than 6 still, then you should think that this is a phenomena of the current pregnancy not being carried before development of the pregnancy.
Thank you. One more question before we close this session.
Yes.
Sharp question, sharp answer.
Definitely. Excellent presentation, Dr. Manoj Maheshwari, as usual. My question is that the diagnosis of GDM is very important. And for diagnosing a patient of GDM, you need a diagnostic criteria. If you see, there is a number of diagnostic criteria available and which are used internationally in different parts of the world. My question is that in our country, which diagnostic criteria you should think personally is beneficial to the patient? Because DMCH criteria has some limitations and you cannot diagnose many of the cases of the if you feel deficient. So what criteria do you see suits for this Indian subset of the patient?
Yes, very good. And you have asked this question for the ease of many of the postgraduates who remain confused with so much of the criteria. If you look for the last 10 years history, you will see that in 10 years before, the situation was really very much fluid. One criteria was saying something, another was saying something, and it was totally confused. Even I think postgraduate has to be confused. Even we people were remaining confused. But as the time is being passed, if you look over those criteria, you will find that most of the criteria are getting closer and closer to their single format, and almost single value they are getting agreed of that. So that is the DIPSI says 95 or less than 95 fasting. IAD PSG says 92. Hardly makes any difference. If you keep 90 less than 95 or less than 92, it's all the playing of the data. In Indian population, on the basis of the population study, they have made their recommendation that said that less than 95 fasting is enough to keep as a control. IAD PSG says no, 92 is the cutoff. So you take the 92 is on the beneficial side. Another is as far as the postprandial is concerned or post-glucose is concerned, everybody is agreeing of this. 140 or more than that, diagnosis GDM. But if you diagnose GDM as 140 or more than that, you should target to 120. For the normal glucose level, for the normal child to be developed, for mother to be avoided from the future diabetes, you should maintain across the pregnancy less than 120 blood glucose. Even at less than 120 glucose, what the study says that 5% children are going to be diabetic in their later life. But we cannot compromise more than that, less than 120.
Well said. Despite all the confusion, the figures are nearing. That was a wonderful presentation, Anuj. There are a lot of questions related to that. We can ask those questions to Dr. Anuj later on also. Because of lack of time, we'll close the session now. Thank you, Dr. Anuj Maheshwari, for your presence and wonderful talk. Let us give him the standing ovation.
Thank you, sir. Thank you. Thank you.
Thank you. Thank you, sir.
I request our chairpersons to please felicitate our esteemed speaker. I also request a speaker to please felicitate our chairpersons. Thank you, sir. To give us the outline of the Community Outreach Program, RSSDI Bihar, I request Dr. Supriyo Mukherjee, sir, to please come up on the stage.
Immediately come in that order to put their point of view. Please, Dr. Supriyo Mukherjee. And to chair the session, Dr. K.K. Jha, Dr. R.K. Jha, Dr. Mohan Paswan and Dr. Neeraj Prasad have to come to the dais as chairpersons. Please.
We are really running short of time, so we discuss our community outreach program here. That is the dream project of our national president, Dr. Anuj Maheshwari. And what happens as a chairman of RSSDI Bihar chapter, I believed rural diabetes care must evolve from isolated effort of cohesiveness to a cohesive people-driven system. And this framework, DARE, that we said delivery, advocacy, research, and equity, which I proposed once I became chapter chair in Bihar. This is basically a DARE philosophy, that is delivery, advocacy, research, and equity. Out of that, we will have a 5-session which will discuss the critical transformation rooted in our filled realities and designed for national relevance. So my topic would be the symptom to system, where I will explore on how Bihar can lead with scalable, tech-enabled, community-integrated detection model, which we have in our mind that we will discuss. And secondly, the advocacy part that will be taken by our chair-elect, Dr. Shehwal Guha, who explores how caregivers, children, community leaders can drive changes using their own voices and local platform. And finally, the research arm of this system by our vice chair-elect, Dr. Subhash, who highlight how localized data, field-led inquiry can produce globally relevant equity-informed diabetes research. And there are two equity components here. One is a geo-equity. That is a very important for this part of the world, because when distance decides health, that will be taken care by Dr. none other than Anand. And finally, our chapter secretary will be done by equity chapter secretary, Dr. Vijay Kumar will deal with the equity is not charity part. That is very important, because we just give 4 glucometer to the people. That is not an equity. That is, equity is not charity. And what equity is not about, equity is not about the more. It is about the fairness. This final talk reinforces the principle that rural lives deserve structured, culturally appropriate and outcome-driven diabetes care, not leftover from urban models. This is what we wanted to say. So my topic, from system to system, symptoms to system, that we all know that around 50% of the rural diabetes remains undiagnosed. Why? Because there are many rural diabetes challenges which involve behavioral, logistic, and cultural dimensions. And the screening gap in schools, maternal care, and routine PSC visits are there. There are missed opportunities, which I published just recently in Curious Journal, Nature Journal, and where we found that the weak referral pathway between village level and higher care centers, insufficient culturally adapted material for local dialects, and language trust consistent workforce training remains pivotal gap that we found. Finally, the tech innovation in rural care, we can very well, that has been proven by the Chunampet project by Dr. V. Mohan, where while he brought specialists to the village, and at the same time, ASHA-enabled, Nikhil Tandon's ASHA-enabled screening application, that is impact model, has very clearly showed that the community workers to triage and refer patients systematically. AI-enabled retinal scans, SMI, IAVR, and point-of-care diagnostics for early detections. So patient behavioral changes and the strategies are far more important, where community awareness via folk media, mobile reminders, and there are many points which we have to discuss. And finally, what are the identified research gaps we had found? There are, again, there's a paper in World Journal of Hepatology where we published inadequate early screening strategies, limited adoption of tech in low resource setting, weak integrations. There are the identified gaps. And what are the solutions? That is the research component of our part that we will discuss. And what are the call to action is a shift from reactive care to proactive system, and empower community health worker with tech and training, and strengthen follow-up and digital tools which make equity central to diabetes care in Bihar. So healing begins when the policy leads, tech enables, and innovation rises from the ground. Thank you very much. Now I will call Shiva.
Good evening, everybody. Beyond awareness, building diabetes advocacy as a rural movement, that's what is a part of bringing diabetes care to the masses, which is the dream child of Professor Maheshwari. So what is awareness? Awareness is basically perception or knowledge about something, जिसको हम लोग जानकारी बोलते हैं, जानकारी या दिलचस्पी. Like we are aware that India is becoming the diabetes capital of the world. We are aware that as per the India study, 8 to 9% of Indians are in the rural population are diabetics. We are aware that 70% of India lives in the villages. But awareness stops there. It's a passive thing. We know that diabetes exists in a large extent in the masses in the rural areas, but we are not doing anything. So all this knowledge is passive, it's useless until unless it's covered in the active form, which is advocacy. What do we mean by advocacy? In advocacy, we simply translate this knowledge, this awareness into action. We know that the diabetes is so much prevalent, so how do we go about increasing this awareness in the masses? What do we do to prevent spread of diabetes, prevent increase in incidence? How do we modify treatment in the rural masses and make it approachable, make them approachable to treatment, and do identify the rights of people living with the disease? Because we have unique challenges in the rural areas where awareness level is about the disease is low, awareness about the treatment available is low. They have very poor access to healthcare. So whatever we do in the rural masses has to be, number one, community driven. So we have to devise and design it according to the target community. It should be context specific. We have to be specific about prevention of diabetes or treatment of diabetes. So contextually, there should be clarity about it. And whatever we do has to be practical and sustainable. Talking about bookish things in the rural status is useless until unless we translate it, bring it down, scale it down to their level. So what are the challenges in the rural areas? First, there are higher rates of undiagnosed diabetes because of poor awareness, inadequate screening, and various other factors. Also, like any rural areas in Bihar, the access to healthcare professionals is very less as compared to the urban population. Access to educators, access to educational material about diabetes is also very limited in the rural areas. Plus, there are certain cultural myths and misconceptions which increase the incidence of diabetes or delays detection. Then poverty and illiteracy are always there. They play their game, they play their part. It affects proper healthy diet. Diets are usually low in proteins, high in carbs because of poverty. Awareness about importance of exercise, importance of treatment adherence. That's another part. A patient sees his sugar level has come down to normal, he stops his medicine. And that's a frequent feature we find in all our patients in our clinics. And then scarcity of healthy food options. You go to a village, you go to any pawn shop, you'll see packets of chips and kurkure are there, but you won't find a food stall or a fruit stall anywhere. So scarcity of healthy food options are always less, more so in the villages. And inadequate facilities for physical activity. There are very social taboos. People have to work at odd times. So proper physical activity, what is needed to prevent diabetes, or for a patient of diabetes, what is needed, is not exactly there. So these are the various challenges. So what do we do about it? We have to aim our diabetic advocacy movement according to that. Like we have to empower the local leaders, the teachers of the school, the health workers. We have to conduct village-level meetings and awareness camps in the local languages. We have to train the frontline workers to identify, counsel, and follow up the patients. We have to develop peer educator networks. We have to do policy advocacy for diabetes medications so that medications and glucometers are available at the PSC level, push for inclusion of diabetes in various programs. We have to design education programs according to the culture with due respect to the local culture. And we have to use folk art, music, storytelling to convey the messages in a pleasant way, in an acceptable way, collaborate with the local NGOs, self-help groups, cooperative schools, and leverage existing rural networks of NGOs and others to use this. At the same time, we have to take the help of technology. We have to use mobile phone-based reminders because mobile phones are accessible even at the grassroots levels now. So we have to teach them how to maintain glucose monitoring, we have to do telemedicine consultations for the challenging cases, and we have to address the social stigmas, create safe spaces for people who are diagnosed, and identify role models from the local leaders who are diabetics and take their help in including. As a whole, in a nutshell, the vision of this rural outreach program is to have a rural community where the community itself is able to prevent diabetes, is able to detect diabetes at a very early stage, manage it effectively, and advocate for their healthcare rights without help from the tertiary care centers. Thank you.
Good evening, everyone. It gives me immense pleasure to extend my heartfelt welcome to our President-elect, Dr. Anuj Maheshwari sir, and our friend, Secretary RSSDI Uttar Pradesh, Dr. Ajay Tiwari. My talk is on research method which we are going to learn for our population, especially in rural diabetes people. जैसा कि आप जानते हैं, अब ये diabetes is not a problem of only urban area. Now, diabetes has been hit by tsunami of diabetes at even rural part of India, and it is across country. So, it is a growing health concern, and we have to understand what is the research design we have to plan for our local population, particularly in rural setting. And we have there is a need for contextual community-based research, which we have to plan. So why we need it? It is because we have to have effectively address the problem. There is urgent need to design a rooted design of research at a ground level. That's why it has it's a particular requirement in our population. Sorry for the slide confusion. Why we need to have a study in rural population? Again, to repeat that, we do not have a homogeneous society in India. We have a different area, different village, different cultures. So we have unique socio-cultural dynamics. Limited healthcare access is a big problem, as discussed by our chairman-elect. And we have a traditional diet and occupation also is another one. And underreporting and late diagnosis is a big issue across India, and it is more in our population because we have less of infrastructure in terms of healthcare. So we need to have a particular research in our setting especially. And to aim the research, we have to understand how our rural environment shape the experiences, management, and understanding of diabetes. If you look at even Bihar, particularly from North Bihar to South Bihar, there will be a lot of differences. कहीं साउथ हमारे इस पार्ट में particularly दरभंगा साइड में अगर खाने पीने का देखें या लोगों का understanding diabetes, they are really relaxed. They won't report to us unless until there is a complication which is already there. So we have to understand their need and their importance of and their understanding of diabetes, and we have to plan actionable research in terms of having a particular contextual related issues. So what questions we have, especially when we talk, what are the local beliefs and perceptions of diabetes? How do rural patients manage the disease is very important to research. What are the barriers which they have, either the distance from their villages to the hospital or some other factors which we need to work, and the solution we have to find particularly to the particular area. As I said, we need to have a lot of opportunity, and we have a lot of options for research in terms of rural diabetes, particularly in our part of the world. And the methods which we can use, we can have any method, either qualitative, but mixed method will be more suitable because we have to have both qualitative and quantitative research where we can capture not only the prevalence but also the deep-rooted problem in population. We can have a group survey, we can have interviews, focus group participation, and we can also take the participant as ASHA worker or traditional health worker, healers, and patient itself. So what are the themes we can have? We can have themes of research in terms of food habit, which was talked, traditional diet versus modern. Now we have rural India where we eat more of junk foods. Access to care, distance, cost, medications are very important. Stigma and community support also is very important. Some of the important theme can be beliefs and myths of rural areas, illness perception. I will just show you one of my paper which we published in 2020 in Journal of Diabetes Mellitus. The topic was diabetes treatment-related myths and impact of COVID-19 on diabetes knowledge, an Indian survey-based study. It was just a simple Google survey which we went around 400 people across, and we could capture some of very important, and similar study can be conducted at the level of our part of village part also. So we could have cultural relevance in terms of understanding it, rural resilience and adopting practices, community-driven models are also available. And if we have learned this, we can tailor a program, which was a vision of our chair, president-elect, that we can have a tailored awareness campaign to the village part. We can have extended village-level primary care center, engage local influencers, and use mobile clinics, and so on. So to conclude, research diabetes, rural diabetes is deeply social and cultural issue. Contextual understanding improves outcome. Rural lessons can guide national strategies as well, and we can go deep in terms of taking care of diabetes in our population. Thank you.
नमस्कार। आज इस ऑडिटोरियम में मेरा तीसरा बार आना हुआ है और इसके लिए डॉक्टर एस झा को बहुत बहुत धन्यवाद, डॉक्टर सुप्रियोदा को धन्यवाद, डॉक्टर नवीन को धन्यवाद। ये जो कम्युनिटी आउटरीच प्रोग्राम हमारे चेयरमैन इलेक्ट RSSDI नेशनल का एक ड्रीम प्रोजेक्ट है, का ड्रीम प्रोजेक्ट है, उसमें मुझे टॉपिक दिया सुप्रियोदा ने, जियो इक्विटी इन डायबिटीज़ व्हेन डिस्टेंस डिटरमाइन द हेल्थ। तो पहले तो ये ही समझना है कि जियो इक्विटी क्या होता है। तो जियो इक्विटी का मतलब है भू न्याय, जब दूरी तय करती है स्वास्थ्य को। मतलब दूरी एक मेजर फैक्टर है कि हमारे स्वास्थ्य पे उसका किस तरह से प्रभाव पड़ता है, और इसीलिए RSSDI ने ये प्लान किया है कि हम इस दूरी को कैसे घटाएं और हम अपने रूरल एरिया में कैसे पहुँचें। तो स्वास्थ्य की समान पहुँच सभी स्थानों पर रहे, ग्रामीण बनाम शहरी क्षेत्र में जो असमानता है वो घटे, और भारत में जो डायबिटीज़ से जो बढ़ रहा है खतरा, इसको कैसे हम रोक सकें या रोकने में कुछ योगदान दे सकें। तो ये केवल एक भौगोलिक दूरी नहीं है, ये एक टाइम की भी दूरी है, समय की भी दूरी है, और एक मानसिकता की भी दूरी है। तो हमें एक भौगोलिक दूरी, एक समय की दूरी और एक मानसिकता की दूरी, इन तीनों दूरियों को पार पाना पड़ेगा अगर हम भारत जैसे विशाल देश में इस असमानता को, जो गरीब, ग्रामीण, वंचित समुदाय को भी हम अपने में समावित कर पाएं। ये सब जानते हैं कि डायबिटीज़ इंडिया में अपना पैर किस तरह से पसार रहा है, और लगभग 10 करोड़ के लगभग 2023 में हम लोग जानते हैं कि डायबिटीज़ के लोग थे, और इसमें जो हैं उनके बारे में सिर्फ पता है। जो डायबिटीज़ हैं उसमें आधे लोगों को ये पता ही नहीं है कि उनको डायबिटीज़ है, और ये ग्रामीण समुदाय में, ग्रामीण जनजाति में, ग्रामीण अवस्था में, ग्रामीण समुदाय में ज़्यादा है, और उसमें सबसे ज़्यादा हर्डल है उनमें जागरूकता और जांच की कमी। और डायबिटीज़ 2009 में ही WHO ने कह दिया है कि डायबिटीज़ एक साइलेंट किलर है, अगर आप अब देर किए तो मौका दोबारा नहीं मिलेगा। और 65% भारतीय आज ग्रामीण क्षेत्रों में रहते हैं, तो हमारे ऊपर बर्डन बहुत ज़्यादा है। ग्रामीण क्षेत्रों में विशेषज्ञों की कमी है, इलाज के लिए लंबी यात्राएं होती हैं, खर्च अधिक है, और चूँकि भारत एक ग्रामीण प्रदेश है और एक बढ़ता उभरता हुआ इकोनॉमिक पावर है, लेकिन जैसे कि अनुज सर और अजय सर ने बताया कि हाँ, हम 5वें से 4थे पायदान पे पहुंच चुके हैं, लेकिन प्रति व्यक्ति आय अभी भी बहुत असामान्य है। तो एक आम गरीब मरीज को भारत में नज़दीकी अस्पताल तक पहुंचने में लगभग 20 से 30 किलोमीटर का दूरी तय करना पड़ता है, और ये दूरी उसके लिए बहुत भारी पड़ती है, क्योंकि वे दूरी से उनकी दिनचर्या गड़बड़ होती है, उनके आय पे इसका असर पड़ता है, और ये सब उनके लिए डायबिटीज चूंकि साइलेंट किलर है, इसमें अवरोध पैदा करता है। शिक्षा, पोषण, व्यायाम का अवसर अब सीमित होता जा रहा है। गरीबी, जनजाति भेदभाव की भूमिका बढ़ती जा रही है। भोजन की गुणवत्ता और फास्ट फूड का प्रसार हो रहा है, और जहां आप रहते हैं वहां का सामाजिक वातावरण भी ये तय करता है कि आपको किस तरह का भोजन, शिक्षा, व्यायाम का अवसर मिलेगा, और इससे डायबिटीज़ के रोकथाम और नियंत्रण दोनों प्रभावित होते हैं। अगर हम राज्यवार देखें समस्या, तो हमारे दक्षिण के राज्य बेहतर हैं, बशर्ते कि हमारे पूर्व के राज्यों के और पूर्वोत्तर के राज्यों की समस्या और ज़्यादा है। तो हमारे नीति निर्धारक लोगों को भी ये संवाद देना पड़ेगा कि वो अपनी नीति में किस तरह का बदलाव करें कि ये असमानताएं दूर हों। चुनौतियां बहुत हैं, और भारत एक बड़ा ही धीरे से बढ़ने वाला देश है, तो ये धीमी गति हमारे डायबिटीज़ के धीमे रफ्तार को तेज कर देती है। तो इसलिए जो नेशनल हेल्थ प्रोग्राम्स है, या आंगनवाड़ी प्रोग्राम्स है, या हेल्थ ऑर्गेनाइजेशंस हैं, एनजीओ हैं, उनको आगे आना पड़ेगा। अगर हम इसको नहीं अचीव कर पाए तो इसकी बड़ी गंभीर दूरगामी दुष्परिणाम आएंगे, और भारत को अगर 2050 के परिप्रेक्ष्य में देखें तो एक अनुमानित है कि लगभग हम 15 से 17 करोड़ डायबिटीज़ हो जाएंगे, और ये वृद्धि 75% होगी 2024 के तुलना में, और आयु से जो उनका बैलेंस होगा वो भी गड़बड़ाएगा, क्योंकि यंग जनरेशन में जब डायबिटीज़ होगा तो हमारे यंग जनरेशन का काम करने का क्षमता कम होगा, और वो हमारे देश की प्रगति पे बाधा डालेंगे, और इसका खर्च लगभग 39 मिलियन होगा। तो ये बहुत ही भारी बोझ हमारे देश में आने वाला है, और इसका मुख्य कारण है जागरूकता और स्क्रीनिंग की कमी, और इसमें असंतुलन। जो भविष्य में संभावित दुष्परिणाम है, उसमें ग्रामीण क्षेत्रों में मृत्यु दर बढ़ेगा, असमानता की गहराई और गंभीर होगी, इससे समाज में विभाजन बढ़ेगा, और वित्तीय बोझ और स्वास्थ्य प्रणाली पे ज़्यादा दबाव पड़ेगा। तो इन सभी बातों को अगर हम ध्यान में रखें, अगर जनसंख्या वृद्धि इसी तरह से बढ़ती चली तो, और डायबिटीज़ भी इसी तरह से बढ़ता चला, तो युवा पीढ़ी आने में डायबिटीज़ से ग्रस्त होंगे, जो हमारे लिए प्रगति में बाधक बनेंगे। उनका समाधान क्या है? यदि हम तकनीक और जागरूकता को जनमानस तक ले जाएं, जो हम कल से करने वाले हैं बिहार में, तो डायबिटीज़ के इलाज में एक क्रांति लाई जा सकती है। साथ में ही स्थानीय सामुदायिक केंद्र को अगर हम प्रशिक्षित कर सकें, कार्यशाला लगा सकें, तो उसका परिणाम बेहतर हो सकता है, और भविष्य में हम अगर नीतियों को सुदृढ़ कर सकें तो हमें आर्थिक और सामाजिक रूप से नुकसान नहीं उठाना पड़ेगा। डायबिटीज़ सिर्फ एक रोग नहीं है, ये एक राष्ट्रीय चुनौती है। धन्यवाद।
Respected chief guest of today's function, respected chairpersons, my teachers, and my dear colleagues. The topic is equity, not charity, reclaiming fairness in rural diabetes care. There are certain disparities in treatment or in problem statement of rural and urban population and rural and urban diabetes. What are the challenges and how do we are going to overcome that? So as we all know, our previous speakers have also said that there is a tsunami of diabetes, and India is going to be the capital of diabetes. The number of people living with diabetes is projected to reach 380 million by 2025, and 17% higher diabetes prevalence rate are there. So what are the factors contributing to disparities? The factors are limited access to healthcare, longer distance to facilities, workforce shortage, fewer specialized diabetes centers in rural areas, limited access to transportation leading to delayed diagnosis and treatment. There are certain other factors like socio-economic factors like rural communities, lower income, lower education level and limited access to healthy food options in rural areas. Certain lifestyle factors like rural communities may have higher rates of obesity and physical activity due to mechanized agriculture techniques, certain newer techniques in agriculture also, lack of physical activity in rural population also, then the approach of fast food or the access of fast food to the rural population also. These are the certain factors contributing to the disparities. What are the need? Why do we need some targeted interventions? We need multifaceted approach. We need improving access to healthcare services. We need promoting healthy lifestyle choices, and we need promoting addressing socioeconomic factors that contribute to diabetes. Now, how do we improve the strategy to improve the diabetes care in rural areas, like telemedicine, which were popular in COVID area? It provides consultation from a distance, but may not detect more serious issues which require physical proximity or touch. Web-based models can be there, available in libraries and certain other churches. Access to internet and digital services are required for those. Sometimes telephone helplines may be there, immediate responses for questions about diabetes, health, self-management, education, low in cost, but limitations are must satisfy 24-hour staffing needs, recruitment and retention of appropriate personnel to answer questions, and availability and affordability of telephone service. Community health advisors, that is a new concept, they can motivate people with diabetes to engage in low-cost, high-impact activities such as walking. Natural helpers who understand their community provide social support. So our community outreach program is totally based on these. We are promoting community health advisors. There are certain limitations to them also, like the burnout and turnover of community health advisors, lack of support for them, and risk of community health advisor dispensing medical advice sometimes. So these are the challenges and strategy to improve. Thank you for patience hearing.
नमस्कार सभी को। मैं आज इस पोडियम के माध्यम से और अपना पर्सनल बिलीफ के माध्यम से भी मैं कहना चाहूँगा कि RSDDI और स्पेशली अनुज माहेश्वरी सर, जिनका ये ब्रेन चाइल्ड है, इन्होंने इतने अच्छे कार्यक्रम की रूपरेखा जो तैयार की है, जो आपने अभी सुना शशि थरूर, जो हमारे मेडिकल फ्रेटर्निटी के कई सारे स्पीकर्स थे, आनंद शंकर जी ने वाजपेयी जी के अंदाज में इतना अच्छा प्रेजेंटेशन दिया। तो ये लोग क्या करने जा रहे हैं इस आउटरीच कम्युनिटी आउटरीच प्रोग्राम के माध्यम से, इसका एक रूपरेखा इन्होंने बहुत अच्छे से प्रस्तुत किया। मैं अपनी तरफ से एक प्रस्ताव कहिए या सजेशन कहिए कि ये डायबिटीज़ को कंट्रोल कर पाना या उसको ये करना किसी भी सरकार के बस की बात नहीं है। इसमें इसी तरह के जो संस्थान हैं, RSDDI, API, IMA, सारे लोगों को मिल करके इसमें काम करना पड़ेगा। और RSDDI इस के लिए बधाई के पात्र हैं कि उन्होंने इस इनिशिएटिव को स्टार्ट किया है, और भी संगठन इसमें आएंगे। मैं अपना प्रस्ताव ये देना चाहता हूँ कि हम लोग का एक वर्किंग स्टूडेंट्स और टीचर्स का एक नेशनल मेडिकोज ऑर्गेनाइजेशन है। यदि वर्क फोर्स के तौर पर में हम स्टूडेंट्स को उसमें शामिल करके यदि सहयोगी रूप से इस कार्यक्रम को और अच्छे ढंग से यदि कर पाएँ, तो मैं इसके लिए, चूँकि मैं बिहार का प्रेसिडेंट हूँ NMO का, तो मैं अपने प्लेटफॉर्म पर में भी इसको ये सहयोग के साथ में यदि हम लोग इसको उठा सकें तो बहुत ही अच्छा कार्यक्रम बन सकता है। तो धन्यवाद, इस पर में विचार किया जाएगा तो अच्छा रहेगा। धन्यवाद सर।
रिस्पेक्टेड चेयरपर्सन सर, हमारे प्रेसिडेंट इलेक्ट आपकी बात को बड़ी गंभीरता से लिए हैं और हम लोग इस पर ज़रूर विचार करेंगे। हमारे प्रेसिडेंट इलेक्ट आपकी बातों को लेके उस पर कुछ मंथन करेंगे। हम लोग इसको आश्वस्त करते हैं।
Thank you, sir. I request our speakers to please felicitate our chairpersons. For the next session, I request Dr. Ajay Tiwari sir, Dr. B.K. Singh sir, Dr. Supriya Mukherjee sir, Dr. Shaibal Guha sir, and Dr. Subhash Kumar sir to please come up on the stage. I request us chairpersons to please invite the speaker on the stage.
नहीं, मैं आप सबों का ध्यान आकृष्ट करना चाहूँगा कि यहाँ पर जो भी बैठे हुए हैं कोई डायबिटीज़ नहीं है, इसलिए मुझे इजाज़त दिया जाए कुछ बोलने का। सबसे पहले तो आप अपने लिए बहुत जोरदार तालियां बजाइए। ये दरभंगा के लायक ताली हुआ, अब हुआ दरभंगा के लायक ताली। तो सबसे पहले तो मैं डॉक्टर एसी झा सर, डॉक्टर नवीन, डॉक्टर मनीष और संपूर्ण दरभंगा के टीम को बहुत बहुत शुभकामनाएं देता हूं और बधाई देता हूं कि आपने वंडरफुल प्रोग्राम किया। और एक बार पुनः ताली बजा दीजिए, जोर से बजाइए भाई। द नेक्स्ट स्पीकर इज, जिसके बारे में क्या कहा जाए, सुबह से हम लोग सुन रहे हैं, ये सचमुच में द कम्युनिटी आउटरीच प्रोग्राम सुनने में, जब पीएसएम का हम लोग बात सुनते हैं, तेसी झा कान में कह रहे थे कि कुछ समझ में नहीं आ रहा है। सो इट इज वेरी डिफिकल्ट टू कम्युनिकेट विद द पीपल। सो कम्युनिकेशन इज द मेजर प्रॉब्लम। ये एक ऐसा प्रॉब्लम है, लेकिन जहाँ चैलेंजेस है वहीं अपॉर्चुनिटी भी है। सो आई इनवाइट learned speaker, our president-elect, Dr. Anuj Maheshwari sir, to come on the stage. अरे भाई अब तो जोरदार तालियां बजाइए। And the topic is community outreach program in India, challenges and opportunity. हमारे माननीय प्रधानमंत्री कहते हैं कि challenges में ही opportunity खोजना चाहिए। Now, over to Dr. Anuj.
थैंक यू। आप यहाँ आके बोलिए तो हम लोग सब सुनेंगे। वी रिक्वेस्ट यू कम हियर। So this is second time I am addressing you. I can understand this is too long session and next second time दोबारा झेलना is very difficult एक ही आदमी को। But this is important because tomorrow we are going to start a diabetes care community outreach program, especially in the rural outreach program in Bihar. So we should tell about the challenges and opportunities what we are already having. जब हम लोगों ने इसके कंसेप्ट पे बात करना शुरू किया तो एक सवाल ये उठा कि why are you looking for the diabetes in rural India? You say that diabetes अगर किसी को हो गई है तो उसे ज़्यादा एक्सरसाइज करना चाहिए, ज़्यादा शारीरिक श्रम करना चाहिए, ज़्यादा मेहनत करनी चाहिए, खान पान में जो है नियमितता बरतनी चाहिए। गांव के लोग तो पहले से ही ज़्यादा मेहनत करते हैं और खान पान भी वो बड़ा सादा सीधा साधा खाते हैं, फिर आप गांव के लोगों में डायबिटीज़ क्यों ढूंढने जा रहे हैं? तो उसका एक जवाब ये है कि जैसे अभी आनंद ने कहा कि 65% हिंदुस्तान गांव में रहता है और यू विल सरप्राइज टू नो दैट कि 2012 में ये 65% 72% था और 2002 में ये 82% था। तो ये जो फास्ट अर्बनाइजेशन हो रहा है, 82% से अब 65 रह गया और थोड़े समय में शायद ये और कम होगा। दिस फास्ट अर्बनाइजेशन इज रिड्यूसिंग actually the villages and lifestyle of the villages which were existing later for so many years before. दूसरी बात, multiple times we have told this thing, the physical activity and its impact on our body is always relative. A lady who is living in the village goes to some river for taking water, वो पानी लेने के लिए रोज जाती है और 4-5 बाल्टी में भर के या 2-3 मटके में भर के सर पे रख करके, इट वॉज ए यूजुअल फेनोमेना इन आवर विलेजेस, ले करके आती थी। ऑल ऑफ सडन एक दिन वहाँ पे कोई बहुत अच्छे एमएलए या एमपी हुए, उन्होंने कहा कि अब आपको वहाँ जाने की ज़रूरत नहीं, हम आपके घर के बाहर नल लगवा रहे हैं। अब उनका वो फिजिकल एक्टिविटी होना बंद हो गया। And once this physical activity has been reduced, this becomes the reason for the diabetes or increasing insulin resistance. तब आप कहेंगे तो अब क्या इसका मतलब तो डेवलपमेंट वगैरह कुछ होना ही नहीं चाहिए, सबको जो है नदी से ही जाके पानी भर के आना चाहिए? No, it's not like that. But we should keep the physical activity at the level wherever it was earlier to remain in our life, in our day-to-day lifestyle intact. If we are using car, if we are using air-conditioned chambers, if we are using motorcycle for our commuting from one place to other place, then we should ensure that we should find at least 75 minutes exercise time in a day. It is important. As far as the Indians are concerned, हम लोग क्या करते हैं? हम लोग हमेशा फॉलो करते हैं जो एडीए कहता है या जो ईएसडी कहता है। एडीए कहते हैं कि 6 दिन में 4 दिन अगर आप एक्सरसाइज कर लें या 7 दिन में 5 दिन अगर आप एक्सरसाइज करें तो काफ़ी है, 45 मिनट्स एक्सरसाइज करें तो काफ़ी है। बट वी ऑल अंडरस्टैंड दैट इंडियंस आर मोर इंक्लाइंड टू हैव द मेटाबॉलिक सिंड्रोम एंड डायबिटीज एज कंपेयर टू द काउकेशियन पॉपुलेशन। तो क्या होता है वहाँ पे? इंडियंस आर हैविंग मोर इंक्लाइनेशन, वी आर गेटिंग, हमारे लिए WHO ने अपने क्राइटेरिया चेंज कर दिए। जो वेस्ट सरकमफरेंस और BMI के क्राइटेरिया हैं, दे आर डिफरेंट फॉर द इंडियंस एज कंपेयर टू द काउकेशियन। उनको ओबेसिटी तब माना जाता है जब वो 30 क्रॉस करते हैं, हमें ओबेसिटी 25 पे मान लिया जाता है। हमारे लिए रिकमेंडेड 23 और लेस देन 23 है, उनके लिए रिकमेंडेड लेस देन 25 है। वेस्ट सरकमफरेंस हमारे लिए 90 है, उनके लिए इट इज परमिसिबल अप टू द 95. So these are the differences. Once the WHO has given these differences, at the same time the exercise also more needed to us. And thrifty gene is very well-known entity which has been developed in the people of this area, those who are living in this subcontinent, India and Asia. When we were having a lot of famines in once upon a time, then thrifty gene has been developed, and which gene has given us the capability of storing the food in our body, which was being utilized when we were not getting enough amount of the food from outside. And that is what we are getting in the form of the visceral fat. Anterior abdominal obesity is that only. So whenever we start eating more but we are not doing the enough exercise, it starts getting accumulated in our anterior abdominal wall. It starts getting accumulated as a visceral fat. This visceral fat and anterior abdominal wall obesity is actually the most damaging thing which is causing a lot of problems to us. And these things has started occurring now in the villagers also. Now the villagers are also exposed to the late night awakening. They are also working late night because computer वहाँ भी पहुँच गया है, television वहाँ भी पहुँच गया है, mobile phone वहाँ भी पहुँच गया है, और they are also using this smartphone. वो हमें बहुत अच्छा लगता है जब वो लोग जी पे और पेटीएम यूज़ करते हैं, हमें लगता है कि हमारी इकोनॉमी डेवलप हो रही है और ये, बट जब वो जी पे और पेटीएम यूज़ करते हैं तो इसी स्मार्टफोन से वो सोशल मीडिया भी यूज़ करते हैं और वो उसको अपने ऊपर बैड इफेक्ट आने तक उसे कंटिन्यूस यूज़ करते रहते हैं. It is said that when you are going to sleep in the night, at least 2 hours before, you should stop using the social media, you should stop using the smartphone, but it is not known to them. It is not known to them that they should also need some additional exercise, whatever they are doing in their day-to-day activity. So Asian develops diabetes at the younger age, it is well known to us. Lower BMI, it is also well known to us. We are metabolically obese phenotype. At the same time, smoking and alcohol is causing harm much more as compared to our competitive Caucasian population which is living in the Western world, on the basis of which or whose guidelines we are following. Even अगर आज हम RSSDI guidelines की भी बात करें तो RSSDI guidelines भी तो replica है IDA guideline और ESD guidelines की. Majority, most of the API guidelines, most of the RSSDI guidelines are followed by are following the ADA and ESD guidelines. So these are the genetic predisposition, changing dietary pattern, physical inactivity, socio-economic factors which are growing in the village areas and village population. They are also responsible for development of diabetes in the villages. And we already have been discussing here that 50% diabetes is undiagnosed. Where is this undiagnosed? We are doing so many camps in the cities, we are doing so many detection activities in a camp, and everybody is being said that you should discover, you should go and check your glucose level whenever you are going any abnormal phenomena in your body, getting more prolonged fever, prolonged infection, something. But still the 50% remains undetected. These 50% actually hidden in that village population which is not explored as of now. So diabetes self-care essentials which consist of the healthy eating, healthy coping strategies, problem solving skill, regular physical activity, regular blood pressure monitoring and medication adherence, they are actually not being exactly adhered in the village population. So if we compare the urban India and rural India, what you can see here, the diabetes prevalence is growing in both the population, but if you compare both these graphs, you will find the same level where the 10 years before was the urban population, urban prevalence. After the 10 years, it is the rural population. You can see it at 5.5% is the urban population who was having that prevalence in 1990. In 2000, this shifted to the village population or rural population. 8.1 was the 2000 population of the urban, 9.1 was the 2010 of the rural. So the growth is exponential and it is just following the urban population's growth by the rural India. Regional variations in diabetes prevalence are also, we can see southern India is more predominantly having the diabetes as compared to the northern India. We are having the bigger population of the pre-diabetes. It would be very nice to see that ICMR study has shown that only 4.5% population is having diabetes in Uttar Pradesh as compared to the 18% population in the Tamil Nadu. But very few of the people have this idea or has seen this fact that 18% population of the Uttar Pradesh is pre-diabetes. They are sitting on the verge of the diabetes and any day they will become the diabetes. But this gives us an opportunity to stop them becoming the diabetes. And this opportunity is not only in Uttar Pradesh but other states also, and we can grab that opportunity by exploring this rural population, by going to this rural population, making the awareness about the diabetes and its complications. So first year, what is the project has been discussed here, are being discussed here or going to be started from tomorrow here. In this project, the first year we are dedicating to the increasing awareness and ensuring the medication adherence as well as ensuring the routine checkup whenever it is needed. Second year, we will do the empowerment with the glucometer and blood pressure instrument. And third year, we shall be looking over focusing over the complication. And after the 3 years, we will be checking that the status of the complications and status of the diabetes control, which was at the beginning was there, how much we could control after the 3 years of that. The undiagnosed diabetes is a hidden crisis, as I said earlier, 36.7% rural undiagnosed population. 2.3% of them are having with the higher rural index, and the treatment gap is there in the participants, those who were 2.3 times more likely to have untreated diabetes than their urban counterparts. Poor glycemic control across the India, not a new thing. Everybody understands this and agrees with that. But reasons of this are socioeconomic barriers like awareness gap, financial burden. Some of the people have got the unaffordability to purchase medication, treatment disparity. Urban treatment rate is 27.8% as compared to the rural treatment rate is 17.7%. So such a high treatment disparity is there. And this treatment rate can be changed by increasing the awareness. So first year would be quite productive enough if we can increase the treatment rate. Those who are not getting their treatment, if we just push them to get the treatment, we can change the scenario. Only 45.2% of the rural individuals with diabetes have access to the adequate diabetes care compared to 68.5% in the urban India. States with the lower human development indices have higher proportions of the undiagnosed diabetes and poorer diabetes care. The cost of regular glucose monitoring and medication poses a significant financial burden for rural population, leading to delayed or inadequate treatment. So awareness, treatment and control by wealth quintals, if we look for that you can see that poorest people are having the lowest awareness, richest people are having the highest awareness. 14.1% people in the poor segment of the income are having the awareness, 37.3% people are having the awareness. But if you look for the control and treatment, you can see there is a vast difference. Awareness is good, and those who are aware, they are also taking the treatment also. But the effective treatment you can see is very less. Even those who are in the higher strata income, those who are having 37.3% awareness, 30.8% treatment they are taking, but only the control is 9.1%. Mean 1/3 people are getting control, less than 1/3 people are getting control. In the 14.81%, we can say the same level is there, less than 1/3 people are having the control. So control is not getting improved despite our all efforts, despite everything what we can do. So limited healthcare infrastructure in rural India, 80% CHC deficit, where the percentage deficit in the required community health centers in rural India. 31.4% are inadequate facilities, and overall 4,413 specialist shortage is across the country is there. Government initiatives are also there for the diabetes management. Government is running the screening and standard care initiative by Ministry of Health and Family Welfare. There is a national program for the prevention and control of the NCDs. There is Ayushman Bharat Health and Wellness Centers. There is the free medications and generic drug access. Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana provides affordable diabetes medication, including insulin at subsidized rate in government-supported pharmacies. But the problem is where? Everything is available, but people don't know how to use and where to get that. People don't know it's to be used for them. Once the facilities are there, but they are not used, they are not remain available when the crisis is occurring. The same thing what happened in the COVID times. Our hospitals were well equipped, but suddenly the lot of oxygen requirements came up and we were not being able to fulfill that requirement. Because we were not used to going and taking the facilities in our community health centers, in our primary health center. Specialized rural diabetes initiatives like in the form of the Rural Diabetes Prevention and Control Campaign, RSSDI Village Adoption Program which we are going to start. There are multiple kind of the program. There is a Chunampet Rural Diabetes Prevention Project what one of the previous speaker was discussing, run by the Dr. V. Mohan. So RSSDI actively contributes to advancing diabetes care by conducting research on the type 2 diabetes, developing clinical guidelines, implementing comprehensive screening program, training community healthcare workers and operating mobile clinics and health camps in remote regions. Important is to increase the awareness and education, expansion of the screening and early detection by mobile screening camp, point of care diagnostic, household screening program. Region-specific approaches should be different. The regions where the people are not really caring for their hyperglycemia, we should be focusing more as compared to those regions where the people are aware and much of the inclined to have their care. Strengthening primary healthcare infrastructure is important, and in this scenario, once we are having so many lack of the specialists and specialty and facilities, 4,413 specialists are lacking. In that scenario, how can we really strengthen the primary healthcare? Telemedicine is the answer for that. Through the telemedicine, we can connect the specialist who is sitting in the Darbhanga or in Patna to a person who is living in some remote village, and we can provide the treatment what should be done. And we can connect the doctor who is taking care. He may not be very well qualified, but doctor is there, or any healthcare professional is there who can be connecting to the specialist who is sitting in the higher center, and he can guide him. This treatment should be given, and you start doing the treatment, and tomorrow morning let me know what is the result of that. So promoting lifestyle intervention, obviously everybody understand that. I don't want to spend more time on this physical activity program, culturally tailored diet counseling, engaging the local influencers, reviving the traditional practice. So lifestyle intervention is understood. Everybody understand that this is needed and everybody is ready to do, but nobody does it. So until unless we understand this is necessary, we shall not be doing it, then probably its benefit will not be there. What the results of research says that lifestyle modification has the biggest impact in lowering the hyperglycemia and HbA1c fall. It is the highest impact on that, much more than the medicine, much more than the insulin, and much more than the metformin. Culturally appropriate dietary recommendations. Now the villages also started using the diet which may be injurious for them, or which may cause the diabetes, which may cause the metabolic syndrome. So they are also needed to be told to increase more fruits, more vegetables in their diet as compared to the more of the carbohydrate. Improving medication access and affordability. Of course, government is the responsibility of the government, but public-private partnership can resolve this problem up to a larger extent, and we can really guide the people that they can go to such places where they can have the free medications being distributed by the government and its agencies like Pradhan Mantri Jan Aushadhi Yojana and other such kind of the places where people can get the medications at the least possible cost. Enhancing the monitoring and follow-up. M-Health solution means mobile health solution, mobile van, SMS-based services, mobile applications can be used for the various solutions. Telemedicine, peer-supported groups can be used there. So in the second part of the RSSDI village adoption program. What we are doing, the person who will be placed in the village for doing the activity of monitoring, he will be continuously remain in touch on the WhatsApp group with the experts of the RSSDI. If any patient shall be requiring any support, immediately it will come in the form of the guidance. So leveraging the policy support, once the 3 years data would be gathered and we shall be able to say whether these kinds of the approach really could help, then we can share that data with the national programs and the government and national authorities so that they can really find their policy on the basis of those data which we shall be collecting together. So community engagement strategies like village health committees, school-based program, we can involve the certain people, those who are the good influencers, as well as health-focused community events could be made the point of care, or could be made the timings can be matched with that. For example, in our Uttar Pradesh, what the village we have been adopted, we usually, they have got a big mela on the day of the Shivratri. So we usually organize our program on that day only. So that majority of the people are coming for the religious season, we try to engage them. Once they will understand, then they will come directly without having any mela, without having any reasons to come there. But still they do not understand, they have to pick in such kind of the festival. The same thing can be done here also. In Barabanki, there is another Deva Mela is a place where we can collect the people, we can have the gathering of the people. So community engagement services to be used, technology-enabled solutions, we are like digital health records to be maintained for that. Artificial intelligence, how much help can be taken. At this point of time, it's very difficult to say, but in the due course of the time, definitely the artificial intelligence would be of the great help. So addressing gender disparities in diabetes care, this is another important issue. Women are not being given enough importance, they are not being given the treatment what they are really needing, and their diabetes is very much different than their male counterparts because of the hormonal changes which she faces during their lives, starting from the menarche to the menopause. What the changes are occurring in their hormonal status, even the cycle of the menstrual cycle, which is giving so many changes in the glucose level because of the change steroid level of the body, then this needs a different perspective of the treatment towards the fair gender. Addressing diabetes in the elderly rural population. There is another problem is that we have got our facilities, our health system has been so much focused towards their good treatment that life expectancy is increasing after the independence. But increasing life expectancy is having its own disadvantages. More of the Alzheimer's, more of the forgetfulness, more of the memory loss, more of the stroke, more of the frailty-related diseases are occurring in our society, for which we need that geriatric treatment, and geriatrically focused treatment is needed there. So elderly people are to be treated. Many of the elderly people are living alone. They are not living with their family member. Kids are not staying with them. They are needing insulin. They forget whether they have taken the insulin or not. Many people call me that, doctor, I don't remember that whether I have taken the insulin or not. What should I do now? Should I take it again or should I skip it? How do you resolve this problem? You don't have the answer. So these people should be needing the support group. For that, we can really resolve their issues, and that support group can tell what should they can have they can develop some system so that if they may not be forgetting. If a person says, one person called up me once a day, he says that, डॉक्टर मुझे लगता है मैंने अपनी 2 बार इंसुलिन लगा ली, अब मैं क्या करूं? तो मैंने कहा आप चिंता मत करिए, रात में 2 बजे का अलार्म लगा दीजिए और 2 बजे उठ करके एक पराठा खा लीजिएगा, तो you will not have any problem. But ये बताने वाला भी तो कोई होना चाहिए. Somebody should be there who can tell this thing. So we need to develop a support group for such kind of the people who can find themselves alone and they are living alone with the treatment. Integrating traditional and modern medicine. This is again an important. Indian traditional medicine, many people are using the Indian traditional medicine. Many a times it is not that much effective as the modern medicine is. But they have got good faith in the traditional medicine. And because of what, they are not ready to switch over to the modern medicine. Nowadays, many promoters of the traditional medicines are also there, who tries to keep their faith fixed, remain there without going towards the modern medicine. So how can we find the resolution of this problem? If we integrate the traditional medicine with the modern medicine, if we combine it with, then probably we can make them, okay, ठीक है, आपको ये चाहिए, आपको मेथी से आराम मिलता है, आपको करेला खाने से मिलता है आराम, आप करेला का रस पियो, पर साथ में गोली भी खाओ. और if the करेले का रस आपका काम करता रहेगा तो हम गोली की डोज कम करते जाएंगे. So these kinds of the integrating solutions shall be required to be needed. So path forward is the urgent public health challenge is to be addressed in this way. Region-specific strategies to be made and collective action is needed to be taken. It's not a one person or one organization who can do its best. We all have to work together for solution of this diabetes kind of the pandemic, which is increasing not only in the form of the diabetes, hypertension, obesity. These all non-communicable diseases are increasing in its prevalence. Hypertension is having the 3 times prevalence than diabetes, having the same complications what the diabetes is having. Obesity is having the 3 times higher prevalence as compared to the diabetes. We are focusing only on the diabetes. How will it work? We need to focus on the comorbidities which are associated with the diabetes and other insulin resistance disease or other non-communicable disease which are responsible for development of the diabetes. When a person is detected to have the diabetes 15 years before, the process of the vascular atherosclerosis starts in its body with the endothelial dysfunction. Endothelial dysfunction starts taking place 15 years before the person is diagnosed of the hyperglycemic. अब 15 साल पहले हमें कैसे पता चलेगा कि ये आदमी को हाइपरग्लाइसीमिया होने वाला है और उसने तो एथेरोस्क्लेरोसिस डेवलप कर ली. And once he is diabetic, 1 year or 2 years before he has got the heart attack. It means we have to target all our population since from the very beginning and increase their physical activity. जितने बच्चे हैं उन सबको physical activity करने के लिए, exercise करने के लिए, weight gain ना करने देने के लिए अभी हम बहुत खुश होते हैं जब हमारा बच्चा weight gain करता है. आप अंदाज लगाइए, जब हम लोग बच्चे थे, हमारी एज के जो लोग भी होंगे, उस समय हमारे पूरे क्लास में अगर 50 बच्चे होते तो 1 या 2 कोई मोटे बच्चे होते थे और उनको भी लोग चिढ़ाते थे मोटा कह करके. आज 1 या 2 कोई बहुत पतले दुबले होते हैं, बाकी 70-75% more than required of their weight होते हैं. So this is the future India. This is the India which we have to see after 10 years. We are 70% population of India is less than 40 years of the age, as per the 2011 consensus. 2011 का जो सेंसस हुआ था, जनगणना हुई थी, उसके हिसाब से 70% लोग हिंदुस्तान के 40 साल से कम उम्र के हैं. They are the people who will become the diabetes after 10 years or 15 years. How can we stop that? So we have to start a lifestyle modification since the child is taking birth and even in the gestational period too. Even in the pregnancy में ही हमें शुरू करना है वो सारी चीज़ें जो कि हमें डायबिटीज़ से बचा सकती हैं. तो इस काम के लिए हम लोगों ने जब रूरल आउटरीच प्रोग्राम शुरू किया तो अपने RSSDI मेंबर्स में एक सर्वे किया. Let me tell you the result of the survey. To engage with rural communities and promote diabetes awareness, prevention and care, need commitment, time and a genuine interest in the grassroots health activities. 244 responses जो हमें मिले 26 अप्रैल तक. 27 अप्रैल को हमने नेशनल लॉन्च किया था, 26 अप्रैल 199 RSSDI मेंबर्स ने रिस्पॉन्ड किया, जिसमें मैक्सिमम लोगों ने गुजरात, तमिलनाडु, महाराष्ट्र एंड यूपी वाज ऑन द 4th. पॉपुलेशन में यूपी सबसे ऊपर है, लेकिन इस केयर के लिए यूपी से 4th नंबर पे लोग आगे आए थे. तो दिस इज अगेन, जहाँ पे ज़्यादा है प्रॉब्लम वहाँ पे लोग में अवेयरनेस भी ज़्यादा है और वहाँ लोग इन चीज़ों के लिए काम करने के लिए तैयार हैं. पर जहाँ पे लोगों में अवेयरनेस नहीं है वहाँ पे लोग काम करने के लिए भी तैयार नहीं है. 151 have previously been involved in the community health service or rural outreach program, and out of those 106 were those who were ready to give 2 to 5 hours in a day for this rural outreach program. I don't know how many Bihar RSSDI people would be happy or would be ready to give their 2 to 5 hours in a day. 2 to 5 hours is fair enough. अगर आप 2 घंटा भी अपने पूरे दिन भर में देने को तैयार हो जाते हैं तो हमारा काफ़ी काम हो जाता है. Thank you very much for your kind listening.
Hello. Thank you, Professor Anuj sir, for sharing your vision about community outreach program. And we are proud to say that we are about to start it in our state, and we are privileged to have you with us during its launch tomorrow.
Yes, it's a wonderful program and wonderful lecture that you have delivered. There are very many grassroots level, and there are many important points which you discussed regarding community outreach program, regarding delivery and care, regarding awareness of the disease. And there's a relationship between the awareness and the wealth. And that wealth, probably it was not, you didn't get any, you didn't get any correlation between wealth and the awareness. As far as the treatment adherence is concerned, probably that is the point. And finally, that we are very categorically thinking in the line of 4 points, that what I proposed to our RSSDI members, very clear point, that is delivery and care, their philosophy that was proposed by me as a chair, that was very clean. The delivery and care, advocacy instead of awareness. That is very different from awareness. Then there's a research, because village outcome, village community is a gold mine of data. If you can really collect it through that, and if you have that point. And fourth is equity. If we mix all those 4 points, then that would be a wonderful thing. And Dr. Anuj, you have really justified your points as a national president. Thank you so very much.
In fact, Dr. Supriyo, your last slide was covering my whole of the presentation. So your last slide has very nicely covered everything what I have spoken, and I would like to borrow that slide from you.
डिस्कशन होते रहेंगे. मैं ये कहूँगा बात कि जो हम लोग कॉन्फ्रेंस में इतना भाषणबाजी करते हैं, बहस करते हैं, इंटरेक्शन करते हैं, उसका जिस्ट यदि गांव की जनता तक नहीं पहुँचे तो ये कॉन्फ्रेंसेस उतने सक्सेसफुल नहीं हैं. और थैंक यू डॉक्टर अनुज महेश्वरी फॉर ऑल दैट. और कल जब आउटरीच प्रोग्राम हम लोग करेंगे तो उसमें इसको और भी डिटेल बात कर सकते हैं. अभी हम लोग के पास समय कम है और इनॉग्रल सेरेमनी है, which I will request every participant to be very brief. Now, Diksha, you can start the anchoring for this session.
First, I'd like to request our chairpersons to please felicitate our esteemed speaker. So I request our speaker to please felicitate our chairperson.
डॉक्टर बीके सिंह को ऑनर किया जाए.
Good evening, everyone. I'd again like to extend a very warm welcome to all the distinguished guests, esteemed speakers, respected faculty members, clinicians, postgraduate students, and delegates present here at the Research Society for the Study of Diabetes in India, Bihar chapter. To commence the inauguration ceremony, I would like to invite our respected dignitaries to kindly come up on the stage and grace the dais with their presence. I request Dr. Anuj Maheshwari sir to please remain on the stage. I request Professor Dr. Alka Jha ma'am, Principal, Darbhanga Medical College, to please come up on the stage. I also request Professor Dr. Sheila Kumari ma'am, Superintendent, Darbhanga Medical College, to also come up on the stage. I request Professor Dr. UC Jha sir, Patron and HOD, Medicine Department, Darbhanga Medical College, to please come up on the stage. Dr. Supriyo Mukherjee sir, Chairman, RSSDI, Bihar Chapter, kindly come up on the stage, sir. I request Dr. Ajay Tiwari sir, Secretary, RSSDI, Uttar Pradesh, to please come up on the stage. Dr. Professor S.C. Jha sir, Organizing Chairman, to also come up on the stage. I request Dr. Saibal Guha sir, Chairman, Elect RSSDI, Bihar Chapter, to please join us on the stage. I request Dr. Vijay Kumar sir, Secretary, RSSDI Bihar Chapter, to please come up on the stage. Dr. Naveen Kumar sir, Organizing Secretary, to please come up on the stage. I also request Dr. Vijay Kumar sir to join us on the stage, please. To commence the inauguration ceremony, I would like to invite our respected dignitaries to kindly come up. I request our respected dignitaries to come forward for the ceremonial lighting of the lamp, a symbol of knowledge, learning, and the light that medicine brings to human lives. All the dignitaries are please requested to come forward for the lighting of the lamp. To deliver the welcome address, I now invite the organizing chairman, respected Professor Dr. S.C. Jha sir, to the podium.
Good evening, everybody. I welcome Professor Dr. Anuj Maheshwari, President-elect, to the soil of the Darbhanga, the heartland of Mithila, the place of ancient wisdom and knowledge. And I also welcome our special invitee, Dr. Ajay Tiwari, Chairman, Bihar Chapter, Supriyo Mukherjee, and our Principal Ma'am, Dr. Alka Jha, our Superintendent, Sheila Sahu Ma'am, and our HOD, Dr. UC Jha, Dr. Saibal Guha, and Naveen, kindly arrange for felicitation of all of them. We are doing it in a very brief because already we are very much late. I request Dr. Poonam Misra to kindly come to the stage to honor Principal and Superintendent Ma'am. उनको ऑनर now I will request Naveen and Vijay to honor Dr. UC Jha after HOD Medicine. Kindly honor Naveen and Vijay. डॉक्टर सहपाल गुहा को ऑनर कर दीजिए आप लोग. चेयरमैन इलेक्ट. Dr. Supriyo Mukherjee. Naveen, kindly honor him. I will request to honor Dr. Ajay Tiwari also, please. Good. Now I will request the previous office bearer, ex-chairman Bihar chapter, Dr. B.K. Singh, who has worked hard for the upliftment of our organization. Kindly come to the stage, and I will request Naveen to honor him. Subhas and Anand, please come on the stage. Of our office bearer whom we are indebted to, Anand, the first secretary of RSSDI Bihar chapter, and Subhas, the longest serving secretary. I will request another office bearer, Dr. Manish, to come on the stage, who is the treasurer presently of RSSDI and who, as a secretary of the 6th annual conference of RSSDI Bihar chapter, he did a lot of hard work. Manish, kindly come to the stage. Anand.
I request Professor Dr. S.C. Jasser to please come up and welcome the audience.
I invite all the stalwarts present on the stage, particularly our chief guest, Professor Anuj Maheshwari, and all the wonderful audience of the stage, office bearers, and the pharma company who has provided the support to conduct this event. And I am thankful to our students also who have so closely attended the session, and I am sure they have been inspired by the wise words of Anuj Maheshwari ji. And I think in the coming days, in the next RSSDI to be held at Kochi, they will contribute with their abstracts, they will participate actively, and by his inspiration and by this Diabetes Update program, we will be inspired to take Bihar further in the field of the research, and the day will not be far when Bihar will be competing with other developed states. Welcome all. Now I request our chief guest who has come to this place. I know his schedule for this month, May. Trust me, he didn't have the breathing space. Today also, he started his journey from Kochi at 5 a.m. and now he is there. And still no fatigue, and he is actively participating. We all stand inspired by him. I will again request him to say a few inspiring words for us.
Respected dignitaries on the dais, respected Principal Dr. Alka Jha, Dr. Sheila Kumari, Superintendent, DARBHANGA Medical College and Hospital, Professor U.C. Jha, who is the Patron and Head of Department of Medicine, Dr. Supriyo Mukherjee, Chairman RSSDI, Bihar Chapter, and he has been from my same college where I have been postgraduated, and he was my senior then. Dr. Ajay Kumar, Founder Chairman of the RSSDI, probably he is not there, he has left. Dr. S.C. Jha, Organizing Chairman, Shaibal Guha, Chairman-elect, Ajay Tiwari, my younger brother, my very good, close to heart friend, Dr. Vijay Kumar, Secretary RSSDI, Bihar Chapter, Dr. Naveen Kumar, who is the Organizing Secretary of this program, and many dignitaries, my dear friend, Dr. Anand Shankar, Dr. B.K. Singh ji, and Subhash. They are the very close to heart people, those who are sitting in the audience. I can't, if I am missing anyone. Naveen, your name I have already taken. Yeah. So, I have already taken the name, maximum people whom if I have missed anyone, I believe that people will forgive me. मैंने काफ़ी कुछ आप लोगों के बीच में बोला, पहली टॉक में भी, दूसरी टॉक में भी, बहुत कुछ बोलने के लिए अभी बचा नहीं है. मेरे ख्याल से आज के लिए तो ओवरडोज ही हो गया होगा, जितना भी बोला है. तो इतना भी अगर हम फॉलो कर लें, तो हम अपने कंट्री को डायबिटीज़ कैपिटल होने से रोक सकते हैं. ऑल प्रेडिक्शन सेज, इनफैक्ट 2006 में WHO ने डिक्लेयर कर दिया था कि इंडिया हैज़ बीन द डायबिटीज़ कैपिटल. आफ्टर आवर गुड एफर्ट्स वी कुड बी, हमारे अपने एफर्ट्स ज़्यादा थे या चाइना वालों की बढ़ती हुई डायबिटीज़ थी, वट एवर वॉज द रेस्पॉन्सिबल, पर हम फिर सेकेंड नंबर पे आ गए. अभी अगर हमें फर्स्ट नंबर पे आने से बचना है तो हमें यही दो चीज़ों पे ध्यान देना है जो मैंने अपने टॉक में कही. पहली तो जेस्टेशनल डायबिटीज़ और दूसरी रूरल डायबिटीज़. जेस्टेशनल डायबिटीज़ को अगर हम राइट टाइम पर पहचान करके उसको टाइमली इंटरवीन कर लेते हैं. टाइमली इंटरवीन मीन्स वी शुड डायग्नोज whenever it is starting, immediately starting the treatment. Either it may be the lifestyle modification, or it may be the insulin, or it may be with the metformin, but bringing down the glucose level less than 122 round the clock in a day. Then we can stop the next generation to become diabetes, as well as we can stop the 50% population of our society to becoming diabetes in this life only. So 50% population means females. Those who are going to have 35 to 50% of the female, those who are developing GDM, they are going to become type 2 diabetes in next 10 years. And we can stop them. And next generation we can stop. तो इसके लिए 2007-8 में हम लोगों ने एक मुहिम चलाई थी, पटना भी मैं आया था उसके लिए, if you people remember that, दैनिक जागरण के साथ में जागरण पहल, और उन लोगों ने उसमें स्लोगन दिया था, एक जांच से बचे दो जान. तो एक जांच माने अगर प्रेगनेंसी शुरू होते ही हमने अपना ब्लड ग्लूकोज किया और उसको कंटिन्यूसली करके देखा, तो हम दो जान को डायबिटीज़ होने से बचा सकते हैं, मदर को और उसके होने वाले बच्चे को. एंड दिस कैन रिड्यूस द बर्डन ऑफ द डायबिटीज़ इन आवर फोर्थकमिंग पॉपुलेशन. दूसरी चीज़, रूरल डायबिटीज़ विच इज़ ए हिडन ट्रेजर ऑफ द डायबिटीज़, वो खजाना है डायबिटीज़ का जो अभी तक छुपा हुआ है और बीच बीच में निकल के आता है और एक अचानक से हमारे सारे समीकरण बिगाड़ देता है। जो अर्बनाइजेशन, वेरी फास्ट अर्बनाइजेशन, पहले 82% हमारी रूरल पॉपुलेशन थी, फिर 72% हुई, फिर 68% हुई, आज 64% पीपल आर लिविंग। तो ये जो घटती हुई रूरल पॉपुलेशन है और बढ़ती हुई अर्बनाइजेशन है, दैट इज कॉजिंग लॉट ऑफ डायबिटीज एंड दैट इज causing the explosion of the diabetes and other non-communicable healthcare problems which are generated from the insulin resistance. Diabetes तो सिर्फ 11% है, hypertension 35% है, obesity 40% है. How can we get rid of all that? The only thing is that we should start doing the lifestyle modification in the beginning of our life, and even it should start from the womb. Lifestyle modification should start intrauterine, and then after taking the birth. We should stop our kids to use more of the glucose or more of the sugar. क्यों? क्योंकि फिजिकल एक्टिविटी अब कम हो गई है। जब हम फिजिकल एक्टिविटी ज़्यादा करते थे, एक गांव से दूसरे गांव पैदल जाया करते थे, तो जब हम अपने फ्रेंड के यहाँ जाते थे तो हमें शरबत मिलता था, वो हमारी उस एनर्जी को रिप्लेनिश करता था जो हम खर्च कर रहे होते थे। पर आज तो हम खर्च कुछ कर ही रहे हैं, सिर्फ रिप्लेनिशमेंट ही हो रहा है। किसी फ्रेंड के यहाँ गए, वहाँ भी जाके खूब सारा खाया। आज सुबह से हम लोग जब से यहाँ आए हैं 2 बजे के बाद से कितना खा रहे हैं, ओनली आई एंड अजय कैन ओनली नो दैट कि हमने खाने। बट समटाइम्स दिस ये जो खाना होता है ये बड़ा परसुएसिव भी होता है। आप अगर नहीं खाए तो अगला वाला नाराज हो जाता है, सामने वाला आपने नहीं खाया था, मेरे कहने से आपने नहीं खाया, मैं लेके आया। But ultimately it is causing increasing insulin resistance, it is causing obesity index is rising, it is causing high level of the diabetes, and it is to be corrected, it is to be checked. We should not really give anyone any continuous request for taking food, or even if they don't want. Unnecessary offering is not required. The time has gone कि जब हमको शरबत का गिलास और एक मिठाई से स्वागत किया जाता था और हम लोग खूब सारा पैदल चलते थे, फिजिकल एक्टिविटी करके सब बराबर कर देते थे। अब हम जब फिजिकल एक्टिविटी करते नहीं है तो मिठाई की भी ज़रूरत नहीं है। बच्चों को मिठाई खाने की आदत नहीं डालनी चाहिए और शुरू से ही उनको इस तरीके से डेवलप करना चाहिए कि उनका मिठाई का टेस्ट उनका डेवलप ना हो। Then they will not be eating more of the sugar in the later life. And we could be able to control their diabetes up to larger extent, control their obesity up to larger extent. तो हमें अपने सोशल सिस्टम में कुछ मूलभूत परिवर्तन लाने की ज़रूरत है, कुछ आमूलचूल बदलाव लाने की आवश्यकता है। बहुत सारे लोग इस बात से इनिशियली एग्री नहीं करेंगे, अरे साहब क्या बात करते हैं, मिठाई खाना छोड़ देंगे, प्रसाद के बहाने मिठाई खाते हैं, भगवान को लगाया प्रसाद, मिठाई खा लिया, किसी भी और तरीके से दिन भर ऐसे बहाने ढूंढते रहते हैं, अब क्या। लेकिन इसलिए क्योंकि हमने टेस्ट डेवलप कर लिया है उसका। अभी अगर हम किसी बच्चे का टेस्ट उस मिठाई के लिए डेवलप ना करें, देन ही विल नॉट बी एबल। आजकल के बच्चे टेस्ट डेवलप करते हैं कोल्ड ड्रिंक के लिए, कोका कोला के लिए और पेप्सी के लिए, एंड दे नीड दैट ओनली। तो कहीं इस चीज़ को अगर हम रोक सकते हैं तो हम बढ़ती हुई डायबिटीज़ को रोक पाएंगे, अपने देश को डायबिटीज़ का कैपिटल होने से रोक सकते हैं। तो आई थिंक दिस इज़ द थर्ड लार्ज रोज ऑफ lecture. Thank you very much for listening me. Thank you.
Thanks, Dr. Anuj, for your wise words. And before we invite Naveen for Thanksgiving, I will invite Ajay Tiwari for a special thing. अयोध्या से वो आए हैं, अयोध्या की धरती से आए हैं, यूपी से आए हैं और मिथिलांचल के लोगों के लिए, यहाँ के RSSDI के ऑफिस बेरर्स के लिए कुछ गिफ्ट लाए हैं। ओवर टू डॉक्टर अजय तिवारी।
ये हमारे प्रेसिडेंट इलेक्ट साहब का वो था कि अजय जब तुम आओगे तो खाली हाथ मत आना, क्योंकि हमारे भाई लोग सब यूपी और बिहार एक ही है और हम लोग साथ हैं। और सभी लोग, जैसे लोगों ने कहा कि अजय तिवारी को अडॉप्ट कर लो, तो अजय तिवारी तो अडॉप्टेड है ही और अनुज सर भी उतना ही प्रेम रखते हैं। तो उन्होंने मुझसे कहा कि तुम रामनामी जो वो है पटके वो लेकर के आना अयोध्या से मंगा लेना और हम लोग सबको देंगे। तो मैं चाहूँगा कि सर आप अपने हाथ से सभी लोगों को पहनाइए, जल्दी जल्दी ले आइए। तो मिथिला और राम जी और सीता जी का तो पहले से ही वो है। तो डॉक्टर, हाँ उससे बन रही है। तो सर्वप्रथम मैं बुलाऊंगा डॉक्टर बीके सिंह सर को, जो पास चेयरमैन है। सर आप मंच पे आइए। डॉक्टर सुभाष, इमीडिएट पास सेक्रेटरी। डॉक्टर आनंद शंकर, द फाउंडर सेक्रेटरी एंड हु हैज re-energized his, please. And Chairman Dr. Supriyo Mukherjee, Chairman-elect Dr. Saibal Guha, Secretary Dr. Vijay Kumar, Treasurer Dr. Manish Prasad, and Professor S.C. Jha, Dr. Naveen Kumar, the Dynamic Organizing Chairman and Secretary, and Dr. B.K. Singh, the ex-HOD, and Dr. U.C. Jha, the Professor, both of you. Sir, it's a pleasure to have you with us. Please join us. And Manish Aage, yes. Saibal, Vijay, support. Good. These are the blessings from Lord Ram, the newly constructed temple, which is the proud feeling for all of us.
Now I call Dr. Naveen Kumar to express the vote of thanks.
थैंक यू सर। गुड इवनिंग एवरीवन। समय तो बहुत हो चुका है, सब लोग बोर हो चुके होंगे। मंच पे बैठे हुए हमारे प्रिंसिपल मैम, हमारी मुख्य अतिथि शीला मैम, तिवारी सर, मुखर्जी सर, एस.सी. झा सर, सहवाल गुहा सर और विजय, और मंच के नीचे बैठे हुए सारे हमारे टीचर्स, सीनियर्स, जूनियर्स, कलीग। आज जो प्रोग्राम हुआ उसमें मैं मुख्य अतिथि का धन्यवाद ज्ञापन करना चाहता हूं, जिन्होंने आज जीडीएम पे बात की और कम्युनिटी आउटरीच प्रोग्राम पे बात की कि कैसे हम लोग विलेज में जा कर के प्रोग्राम कर सकते हैं और वहाँ पर डायबिटीज़ कंट्रोल कैसे कर सकते हैं और डिफरेंट ईयर्स में क्या उनका थीम है। और मैं सुपरिटेंडेंट मैम, प्रिंसिपल मैम का भी धन्यवाद ज्ञापन करना चाहता हूँ कि वो इतने व्यस्त समय में से समय निकाल कर आए और यहाँ हम लोगों को आशीर्वाद दिए। मैं यूसी झा सर का धन्यवाद ज्ञापन करना चाहता हूँ। जब हम लोगों का CME होने की बात थी तो फ्रॉम फर्स्ट डे से ही वो हम लोगों से साथ रहे और हम लोगों को बहुत सपोर्ट किया। उनके सपोर्ट की वजह से ये सब कुछ हो पाना संभव नहीं था। ST झा सर जो हमारे टीचर भी हैं, मेंटर भी हैं, उनका भी मैं धन्यवाद ज्ञापन करना चाहूँगा कि जो हमारे साथ हमेशा रहे और किस तरह से काम करना है और किस तरह से CME को सक्सेसफुल बनाया जाता है उन्होंने बताया। मैं मुखर्जी सर का भी धन्यवाद करना चाहता हूँ जो चेयरमैन हैं RSSDI बिहार के, कि उन्होंने बताया कि किस तरह से करना है। और हमारे और भी जो ऑफिस बियरर हैं, सहवाल गुहा सर, विजय एंड आनंद शंकर सर, VK सिंह सर, सुभाष सर, मैं सभी का धन्यवाद ज्ञापन करना चाहता हूँ जो इतने दूर से आए और हम लोगों को आशीर्वाद दिए। हमारे PG स्टूडेंट्स भी हम लोगों के साथ रहे और प्रोग्राम अच्छा रहा। उनके बिना ये प्रोग्राम सफल नहीं हो सकता था। आप सभी लोगों का बहुत बहुत धन्यवाद। थैंक यू।
और मैं विशेष रूप से धन्यवाद अपने फार्मा पार्टनर 3 डॉट और सन फार्मा को भी देना चाहूँगा जिन्होंने इस प्रोग्राम को हैसल फ्री बनाया।
थैंक यू। मनीष का नाम छूट गया था। मनीष, तुम्हारा जो सपोर्ट रहा वो बहुत ही बड़ा सपोर्ट था, तुम्हारे बिना ये नहीं हो सकता था। अब हम लोग नेशनल एंथम के लिए खड़े होंगे।
जन गण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा। तव शुभ नामे जागे तव शुभ आशीष मांगे। गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
थैंक यू। अब मैं जितने भी यहाँ PG स्टूडेंट्स हैं उनको स्टेज पे बुलाना चाहता हूँ और एक ग्रुप फोटो होगा। पहले PG के साथ पहले कर लेते हैं, बाद में इंक्लूडिंग टीचर्स। सर आ जाइए।
कुछ PG स्टूडेंट सामने से बैठ जाएं जिससे कि 2-3 लेयर में फोटोग्राफी अच्छी से आ सके। काइंडली सम ऑफ यू सिट डाउन ऑन द फ्रंट। उमेश सर एंड दामोदर सर, रिजवान सर, रिजवान सर, मनीष सर, अमित सर, आइए जल्दी जल्दी आइए। आओ ना दानिश, कुणाल, आओ जल्दी जल्दी।